very good afternoon to the August gathering. As we gather here today to celebrate meetings which of academic origin are common. But when you have somebody who is indeed the doyen of modern day hepatology and who's hearing him for hours and hours makes listening and loving hepatology a pleasurable experience. We have with us Professor Patrick Kamath, who needs no introduction, and for the next 4 hours or so, we'll delve deep into clinics in hepatology and liver diseases. For beginning of the session, I would like to call upon stage Professor Ajay Duseja, who is the current head of hepatology at Postgraduate Institute, Chandigarh, and also the current Secretary General of International Society of Liver Disease. Ajay sir, please.
Thank you, Akash, and on behalf of the Indian National Association for Study of Liver in ASL, it's my honor and privilege to welcome you all to this, I said yesterday, the first edition of liver clinics by Dr. Kamath. I think those of you who belong to gastroenterology and hepatology fraternity, you know that we have this session every year, in the annual meeting of INASL, and this is usually a 1-hour session where Dr. Kamath, discusses, various liver-related issues, but which are more peculiar, deep into hepatology or for gastroenterologists. But then, a lot of suggestions came to us that, this kind of exercise is required at the physician level, and day-to-day cases also needs discussion. So then, finally, I think we planned it out, and he very kindly, agreed for this. So today's session, which will be over 4 hours, is not, the difficult kind of cases which are usually seen in hepatology or gastroenterology practice, but these are day-to-day cases which are seen in more of, internal medicine practice. So this is more for physicians, less for maybe gastros. This is one. About Dr. Kamath, I think, as I said, you've seen him. He has come only for these 2 days of meeting. Yesterday we were in Bangalore, and he continuously, for 5 to 6 hours, he was on the dais and covered on different aspects. And today he's here, and to tell you, he's flying back today midnight at 12 o'clock. So he's come only specially for this, and our special thanks to him. Professor Kamath, those of you who don't know, he is the professor of medicine and consultant in gastroenterology and hepatology at Mayo Clinic, Rochester, Minnesota, US. His initial medical schooling happened in St. John's Medical College, Bangalore, MBBS. Then that time, if you all know, there used to be a first year or house job medicine that he did in All India Institute of Medical Sciences, and then moved to PGI. So those of you who are from PGI, you should be proud that he was in PGI for more than 4 years. He did his MD medicine from PGI Chandigarh, and then DM gastroenterology from PGI Chandigarh. He moved back to St. John's Medical College for a few years, and then to Mayo Clinic for his research for 5 years. Came back again, but then for various reasons in 1991, he finally moved to US, and he's there since then. I think more than now, it's 35 years. So thank you very much, sir, for taking out time. And I think you're coming specially for this. And as I said, on the way, we are going to make it, if not every 6 months feature, this will definitely going to be an annual feature, and we are going to bother you for this. So before we start the, all the cases and all the discussion, I'll request Professor Kamath and all the dignitaries, Professor Chawla, Professor Puri, Professor Kaushal, Professor Kar, Professor Ashish, everybody, all the faculty to please join us for the lamp lighting to take the, to worship Goddess Saraswati, and then we take it off. Please.
Saraswati Namastubhyam Varade Kamarupini Vidyarambham Karishyami Siddhir Bhavato Me Sada.
As we move on, I'll request Professor Kamath to make the audience be aware about the format of the meeting.
Well, thank you so much, Ajay, for inviting me. Always a pleasure to come to India. I really look forward to future trips. Always, there are so many so we trained together. Yogesh and I trained almost at the same time, so we've been friends for more than 35 years. So I'm always happy to come back. Enough notice, I will come almost any time. So this is mainly for those who are physicians, not for hepatologists. So there are a lot of patients you're going to see. They're going to be patients with elevated liver tests. So we'll talk about how we approach them. You're going to see people with alcohol use, which affects the liver. You're going to see fatty liver disease. There's viral hepatitis, but I won't talk about viral hepatitis today because I don't see as much as many of the experts in the front row will see. And anytime you want, please feel free to interrupt me if you have questions. I'll also leave time at the end for some questions. Okay, we'll try and make this interactive. So this is the protocol for the session. I'll present the case and you give me a show of hands of what you would do. I'll have some comments from the experts here and then we'll have teaching points from each of the cases. So just so that you understand how we are going about it, we'll have a non-medical case, okay? So let's start with show of hands so you understand. Again, national game is hockey, not cricket. Officially, it's still hockey. So there are lots of records in hockey. So India recorded the highest number of goals in Olympic history in the finals versus USA, 1932. What do you think the score was? Let's see a show of hands. Final score. I think there is, you know the score? I'll give you 4 choices.
24-1.
Very good. 16-1. Can you hear now? So I'll need this. Okay. So you have choices. There are going to be 2 hockey questions, one now and one later. 16-1, 21, 24-1, 28-1. Which one? 24-1. Very good. Do you know how that one goal was scored for USA? Anyone knows? The goalkeeper was behind the post signing autographs because he had nothing to do while the goals were being scored and the ball came out there and that's how they scored. That's the only goal scored. We have one more question later about this. So this is the format. You give your comments and then we'll have some teaching points from that, okay?
So the first part for the first session, which is an approach to abnormal liver function test, could I please call upon stage the chairpersons for the session, Dr. Premashish Kar, Senior Director and Head of the Department of Gastroenterology and Hepatology, Max Super Specialty Hospital, Vaishali, and Dr. Pankaj Puri, who is the Director of Gastroenterology and Hepatobiliary Sciences at Fortis Escorts Liver and Digestive Institute, Okhla. I request the chairpersons to also invite on stage the panelists for the session.
May I invite the panelists, Dr. Sunil Dadich. Dr. Sunil is the professor and head Department of Gastroenterology at SN Medical College, Jodhpur. Dr. Ankur Jindal, who's the additional professor in Department of Hepatology at ILBS, New Delhi. And Dr. Kaushal Madan, who's the principal director and head clinical hepatology at Max Super Specialty Saket.
So one of the most common things you're going to see in your general medicine practice is elevation and liver tests. So we'll go over how you approach AST and ALT, alkaline phosphatase, and bilirubin, okay? So this is true story. Advanced gastroenterology fellow came into my office 6:30, sweating. AST 15,300, ALT 9,450. Your choices. Call the next fellow on the waiting list. Alert ICU for admission. Who wants to call next fellow on the waiting list? ICU for admission. Call family to talk transplantation. Anyone? Which one? B. D. Okay. Tell him not to sweat on your desk. Okay. Comments?
Sir, since the AST, ALT both represents they are the markers of acute liver injury. So this fellow has got a severe acute liver injury. And since the AST is more elevated than ALT, that would indicate the source of AST could be a non-hepatic, because ALT always comes from liver, but the AST can come from any other source other than liver. So apart from a acute liver injury, we should also suspect some other source of acute liver, the rise of these enzymes. So you'll need some more points in the history also.
So what will you do?
Second choice, alert the ICU for admission. Yes.
So you will A, B, C, or D?
B.
B.
Yes.
You'll call the, okay. So this is important to know. So remember, he is well, he's come to you with lab tests in his hand. So this is someone well. So remember, when someone is well and markedly elevated liver tests, this is what you should be thinking of. Okay, we'll talk about it. So anytime you say patient AST and ALT greater than 10,000, what do you think of? Do you want any comments?
So it may be ischemic hepatitis, it may be...
So ischemic, very good.
Some toxin or drug-induced liver injury.
Good. Drug.
Or congestive hepatopathy maybe.
So that's part of ischemic. Congestive by itself won't go. We'll talk about that. But that's part of ischemic. I agree. Drug.
Viral maybe sometimes.
Which virus? A, B, C, D,
hepatitis
E.
A, E.
Usually the unusual ones. We'll go, okay. Any other possibility?
So I think in the tropics we see very frequently this kind of enzyme elevation in dengue patients. Patients who have dengue hepatitis, we see this kind of enzyme elevation.
Good.
Among viral.
So this is what you should think of. So you'll see a patient with elevation greater than 10,000. This is your differential diagnosis. Ischemic, we'll talk about that in more detail later. Can you hear me at the back? I'm getting some... Can you hear me clearly at the back? You're okay? Yeah. So unusual viruses, herpes, varicella, chikungunya, dengue gets very high. Paracetamol. Remember muscle injury. Muscle injury, muscle releases AST and ALT. AST has a shorter half-life than ALT. AST half-life is 18 hours. ALT 36 hours, so after 3 to 5 days, ALT is higher. Okay, so muscle injury. So never check blood tests after a person has been running. So long distance running on a hot day can release these enzymes. So when a neurologist calls you, patient with status epilepticus, don't worry, it's from the muscle. So these are the enzyme patterns with muscle injury. CK more than aldolase. So whenever you have this, if it doesn't look like liver, patient is well, nothing to suggest virus, check the CK in this patient. AST is shorter half-life than ALT, remember that? So after 3 to 5 days, ALT will be higher than AST. So in general, if you see a patient who's really well, AST and ALT are elevated, remember it is possibly from muscle. Consider that as a possibility. So when we talk about normal enzyme levels, the enzyme levels previously are changed a little. Now they are a little lower. Women less than 25, men less than 33. This is in the US, and I learned yesterday from Ajay, in India it is now 35, correct? The laboratories have not changed as yet, but it's a little low. Was my number correct? Yeah, thank you. So when you get a patient with an ALT greater than 500, usually chronic liver disease doesn't give you levels more than 500. So if it's more than 500, you're thinking acute hepatitis. So acute hepatitis can be viral. Testing is very easy. Next is likely to be drugs. So it's going to be viral or drug. And drug, you know the medical history, the timing of the drug. So that's a clinical diagnosis. I have put alcohol-associated hepatitis here. By itself, it does not give AST and ALT more than 500, but if they're also taking other medications at the same time, because they tend to take a lot of paracetamol and all for pain, then the AST and ALT can be more than 500. But otherwise, think of virus, think of drugs if it's more than 500. Okay, so 500 is an acute hepatitis, virus, or drug. This is a little more for the endoscopists, but again we're talking about how AST and ALT can increase. So we have a 63-year-old woman, 4 hours of abdominal pain, fever, nausea, blood pressure is okay, jaundice, epigastric tenderness, leukocytosis, alkaline phosphatase little elevated, AST and ALT greatly elevated, okay? Ultrasound shows gallstones, normal pancreas, blood cultures are positive. So looking like cholangitis. Patient has gallstones, looks like cholangitis. So these are your choices, and I'll ask the panel. EUS, MRCP, ERCP, laparoscopic cholecystectomy, or do you want to do a Doppler ultrasound? We can start the other side. Kaushal, do you want to start?
Since there is high pretest probability of finding a CBD stone, I would in one sitting go for EUS followed by ERCP if a stone is confirmed.
So EUS first followed by ERCP. Anyone?
If you want to be non-invasive, then MRCP first.
Okay. What do you think?
I will go with MRCP and followed by ERCP if stones are there.
So remember, we'll go over the guidelines. So generally, EUS, not a bad idea. MRCP, again, not a bad idea, but MRCP is not as good for stones as EUS. So if you're picking one, pick EUS. But here the patient has cholangitis, has gallstones, ERCP, because if the EUS is negative and the MRCP is negative, we'll still go for an ERCP. So go straight for an ERCP here, and I'll show you why. Later, the patient can have a cholecystectomy. Doppler ultrasound does not explain fever. Can explain a lot of other things, but does not explain the fever. So these are the current recommendations. When should you do an ERCP? High probability. Stone, if you see the stone, if the patient has cholangitis, bilirubin more than 4 and dilated CBD, high probability that this is stone. So in these patients, you'll go straight for an ERCP. Intermediate, cholangitis is not clear. Some elevation in the liver test, dilated CBD, then you can consider EUS, MRCP. If the patient is going for a cholecystectomy, my preference has always been send the patient for a cholecystectomy. The surgeon can do an intraoperative ultrasound or a cholangiogram at that time and decide. But in these patients who don't have cholangitis or dilated ducts or you don't see a stone, it would be reasonable to get an EUS or an MRCP. And if they have no features at all, no cholangitis, no fever, liver test not elevated, send the patient straight for cholecystectomy, no need of any additional tests. So we spoke about causes of greater than 10,000. Then we said 500 is acute hepatitis, think of virus, think of drugs. Now this is a US study, so the numbers may be a little different here. Patients with AST and ALT more than 1,000, typically you're going to see them in hospital. What should you think of here? Ischemia is common. Pancreatic or biliary causes. Stones can cause AST or ALT greater than 1,000. Remember that. Drugs, virus. So over 500 we said drugs or virus. Over 1,000 still drugs or virus. But ischemia is much higher. Now we're getting ALT more than 5,000. Drugs, ischemia. AST is a mitochondrial injury. So ischemia tends to damage mitochondria. So ischemia tends to cause higher elevation of AST than ALT. So AST more than 5,000, think of ischemia, and drugs are next. So just based on the numbers, you can get some idea about what you're dealing with. So you don't have to do a lot of tests. Yeah. Question? Can you take the microphone to... You're not going to bowl googlies, are you?
My question is that in the previous case you showed, the ultrasound did not show any biliary radical dilatation.
Correct.
Only it showed gallstones.
Correct.
And so going straight away for ERCP, I think many people here would be skeptical and they would first like to confirm on EUS or MRCP rather than going for
So good question. So the comment is, why go straight for an ERCP? So he's got cholangitis. So elevated tests and cholangitis. So blood culture is positive. So the question to you is, EUS did not pick up a stone. MRCP is not that good, does not see a stone. What will you do? Will you do an ERCP or you would say, no, stone, I'm not going to do anything?
But having stone, yeah.
No stone seen on EUS?
Because EUS, I think, would pick up stones. I think it's very sensitive for picking up stones. So if we get a EUS done and suppose there's no stone, then going for ERCP would be having a high chance of negative ERCP, and then we might also introduce infection further up.
So if you saw a patient like this...
So if EUS did not show a stone,
correct,
then going for ERCP might be
so
even...
you wouldn't do any. So the question is, if EUS did not show a stone...
I would look for any alternate cause of having his high counts and all that, rather than going for ERCP.
So you think it's systemic sepsis of another cause?
Yeah.
Causing such high elevation? So sepsis is
because
more polystatic injury. So pneumococcal pneumonia can cause high AST and ALT. So you're trying to explain the high AST, ALT, bilirubin on the basis of E. coli infection somewhere else.
Yeah, because EUS missing a CBD stone would be very rare, in my opinion.
And so then you would think a urinary source. The question is, what will you do next? So if you've ruled out stones, so
See,
where are you going to look?
there's no IHBRD, and if EUS is also negative, then the jaundice which the patient has might be just cholestasis of sepsis.
And the AST and ALT, 10 times the alkaline phosphatase is minimally elevated, AST and ALT rapid, so sepsis doesn't cause AST and ALT elevation in one day. No, I'm just saying, difference. I would if I see a patient like this, for me it's ERCP, and the guidelines also support that. Because what I'm trying to say, we shouldn't do too many tests. But again, accepting the argument that this is not stone, my question to you is, where is the infection from? What is the next test you would do?
Dr. Assis, I think as per the Tokyo guidelines,
both points are valid, but my thought process on this is maybe it's a stone which is passed out already, and if we should first look at doing an endoscopic ultrasound. If the endoscopic ultrasound does show a stone, obviously we'll do ERCP. If it doesn't, we would give antibiotics and watch and see if it settles down. Look for alternative causes of sepsis. The stone may have already passed out. Doing a ERCP has a 5% risk of pancreatitis besides the other risks. And if it does happen, we are not likely to be able to explain why we have done the ERCP in the first place to the patients and the relatives.
So
okay.
follow-up LFT is important. So you can do day one, then follow it up on second day or third day. But as per the Tokyo guidelines,
hepatologists, let's see, who would do an ERCP here? So it looks like I'm in the minority. Who would do an ERCP? 1, 2, at least I'm not alone. 3. Where's my ERCP friend? You do EUS?
No.
Yes, sir.
EUS.
So my point really is that in India, we have got tropical infections as the common cause of jaundice with this kind of a presentation. The alphos isn't really very elevated. It can happen. The AST-ALT is much elevated. The alphos is not that elevated even in stone disease. But this could be an enteric fever. This could be a...
No, it's E. coli positive.
No, I mean, we haven't tested for that. So we would send the cultures and give the antibiotics, and if it maybe doesn't settle down at all, then we would be considering.
No, I think we said, so we've got the cultures positive for E. coli. We've got these elevations. And what is the probability of something other than cholangitis? To me, it's high probability. Guidelines suggest high probability. But maybe in your setting, it's not a high probability of stones, and then you can do the EUS. This is different ways people approach that. So I like to always go very direct to try and get the diagnosis. So you can see in later things, I go for biopsy very quickly in these patients. So I don't delay stones. So you do EUS and the same session ERCP at that time. Okay.
I think in today's era, when you have EUS in the same endoscopy suite as the ERCP, it just takes 5 minutes to just put in an EUS and confirm whether it's a stone or not. And I agree with Dr. Puri when he says that there is a minor chance that it could be a passed out stone. And then it will be very difficult to explain why we did it in the first place, why we did the ERCP in the first place.
So the jaundice would not be enough to explain why you did the ERCP with the stone passed out?
No, if something wrong happens, I think it will be very difficult for us. And that's why you did not see so many hands up when you asked.
So, okay. Reasonable.
People would be happy spending extra for that EUS, but they wouldn't be happy if they get a complication of ERCP and you're not able to explain it.
Yeah.
I'm talking about the patient family.
And so finally, if your EUS is negative, you're extremely confident that there is no stone, and you won't do an ERCP. So that's my question. What's that? Okay.
Dr. Brajesh, who's ready to do ERCP without US, so I would like to ask his viewpoint.
Just for the audience, can you use the phone, the microphone?
He's on your side, sir.
So this side. Especially this thing is to Dr. Puri also. Patient gallstones, jaundice, fever, blood culture positive. And for passed out stone, cholangitis is continuing, jaundice is persisting, and fever is persisting. There is no fall of jaundice, no relief in fever. So passed out stone I will not think of. I will straightway go for ERCP. And second thing, Dr. Puri, I tell you one thing. This patient comes to you.
You think this couldn't be UTI sepsis?
No, just listen to me. This patient comes to you with gallstones, jaundice, fever, positive culture. And he gets EUS from outside, EUS no stone. In this stage, will you not do ERCP or you will rely on EUS report?
There are many other reasons for sepsis. E. coli sepsis could also be from cholecystitis, not necessarily from cholangitis.
Please
Doing a
listen to
ERCP is not going to be... Let me finish.
Sepsis is caused by so many causes. But you see, a patient with gallstones, fever and jaundice, what possibility will be there the cause of sepsis? How many cholangitis, how many non-cholangitis? That is very clear.
This patient doesn't have a raised alkaline phosphatase. This patient has gallstones. This could be cholecystitis. If your thinking is pancreatobiliary, it could be something... Sir, patients, what are the bilirubin levels? 2, I thought.
Yeah, no, it was 5, but I think repeating bilirubin level will solve the question.
I think
we'll do...
people want me to move on. I'm with you, Bridget. I would go for the ERCP, but I agree there's another... So that's the thing about medicine. You know, there are different ways you can reach the same decision finally. So I think it's okay. If you're more comfortable with an EUS and then do an ERCP, I think that's fine. Me, may be different. Again, it depends on the situation we are in. So I'm okay with that. I think if it's frozen. Okay, so when acute hepatitis, you think level is more than 500, you've checked for viruses and the tests are negative, think of drugs, it's very common, autoimmune hepatitis, unusual infections, intermittent partial biliary obstruction, so that sleep apnea, don't forget you have an obese patient, AST and ALT go up intermittently, sleep apnea can cause that. Malignancy, lymphomas, leukemias can infiltrate the liver, cause high AST and ALT. Remember that. And if the patient is not improving, no clear etiology identified, consider a liver biopsy in these patients. So we said drug-induced liver injury is very common, and there's no good test for drug-induced liver injury. And if the patient is on multiple drugs, which one has caused the liver injury? That's always difficulty. Remember a simple rule. The drug which was started closest to the liver injury is most likely the cause. If they all have been there for greater than 4 weeks, drugs given in grams more likely to cause liver injury than milligrams than given in micrograms. So antibiotics, anti-tubercular drugs are all given in grams, much more likely to cause liver injury. Micrograms, thyroxine, you'll hardly ever see liver injury when drugs are given in very small doses. So there's just a simple rule to find out which drug was actually the cause of the liver injury. So questions from the audience on AST and ALT. Do you have any questions? So remember 500, 1,000, 5,000, 10,000. That's generally you can get an idea. If it's persistently less than 500, that's chronic liver disease. Okay. Then you have the alkaline phosphatase. Should you check it fasting or postprandial? Anyone who wants to check it fasting? Postprandial? Why fasting? You look like postgraduates. Why fasting? Yes, because alkaline phosphatase goes up after meals. So anytime you check the alkaline phosphatase and it's elevated, first question you ask is, was the patient fasting or not? Because it tends to get elevated. So if the alkaline phosphatase is elevated, there are multiple causes here. Again, based on the clinical situation, consider what it is. So it can be obstruction, can be drugs, inflammation, or infiltration. Okay, so there are multiple causes there. The importance is, how do you actually approach these patients? So when you see an elevated alkaline phosphatase, check it again. Still elevated. Rule out physiological causes. Pregnancy causes elevation. Remember, alkaline phosphatase is elevated in children. Postprandial increase. So you've done it, so you've repeated it, patient is fasting, alkaline phosphatase is still elevated, then you have to do more testing. So the next question is this from the liver or is this from the bone? So you can check the gamma GT or you can do isoenzymes. If you confirm it is from the liver or from the bone. So if gamma GT is normal, alkaline phosphatase is up, this is alkaline phosphatase from the bone. Don't do any more liver tests here. You have to look for bone disorders. But if the gamma GT is elevated, that is liver disease. So then you have to look for what in liver disease would cause this. So you will do a right upper quadrant ultrasound first. If the bile ducts are dilated, MRCP or ERCP, depending on the situation. No biliary dilatation. This is likely to be intrahepatic cholestasis. If it's a female, I know AMAs are positive here. I don't know whether you check that routinely or not. That's the next test that we do. If the AMA is positive and the ultrasound is normal, or the AMA is negative and the ultrasound is abnormal, we will go for a liver biopsy. If the AMA is negative and the ultrasound is normal, it's probably not much of a problem, but see how high the alkaline phosphatase is. Is it rising? Is the patient symptomatic or not? If the patient is having fevers, weight loss, consider a liver biopsy there, even if the ultrasound is looking normal. But it's less than 50% elevated, not rising, just watch these. Recheck in about 3 to 6 months' time, okay? So just a simple approach to alkaline phosphatase. Questions on alkaline phosphatase? Anyone? Panel, do you want to make any comments? Is this your approach too? Only issue is, do you check AMA at all?
So when there is no biliary ductal dilatation, we think of infiltrative liver disease first, rather than AMA.
Oh, sure. So you skip that completely, is it? You never check the AMA. So after biliary dilatation,
if there is no HBR dilatation, more likely to be infiltrative liver disease like tuberculosis.
No. So that means really you're going to either a liver biopsy. So if AMA is negative, is there any level of, this is for the audience because we do it a little different. So what is the level of alkaline phosphatase you go to before you do a liver biopsy, or would you do a liver biopsy in everyone if there's no biliary dilatation?
So if there is no biliary dilatation, high ALP, borderline elevation of AST, ALT with clinical setting of maybe a low-grade fever or something.
So the setting is important.
Yes, setting is
so
more important.
That's what we're saying. Yes. The setting is very important.
So AMA only when there is a female, middle-aged, some other symptoms.
So this is an important point. Alkaline phosphatase elevation, the biopsy is in the clinical situation. If it looks like this is granulomatous disease of the liver, tuberculosis, lymphoma, all these can cause an elevation. So all your tests have to have based on the clinical presentation here. And then we have approach to patient with jaundice. Okay, so jaundice is serum bilirubin of greater than 3. can be divided into indirect hyperbilirubinemia. Remember, I know when I was, even when I was doing my DM and after that, we always taught that direct bilirubin is more than 50% direct. But we know that is incorrect because about 95% of bilirubin is indirect normally. So any elevation in direct bilirubin is abnormal. So 20% of the bilirubin is direct, that is direct hyperbilirubinemia. 80% indirect is indirect hyperbilirubinemia. It's not the 50% which used to be there before. It's just the way the test is measured. So if you have indirect hyperbilirubinemia, evaluation very quick and very simple. Look at the hemoglobin. Hemoglobin normal, indirect hyperbilirubinemia. So no anemia, this is Gilbert's syndrome. Typically of no clinical significance. Any advantage in having Gilbert syndrome? What is the advantage, what is the disadvantage other than insurance?
I don't know.
What's
Advantage?
What is the advantage? Very good. Who said
protective.
that? You're an endoscopist, you shouldn't be reading. You should just be cutting, burning, don't read. But you're right. So cardiovascular, all-cause mortality is decreased in people with Gilbert syndrome and cardiovascular is decreased. Question back to you, is there a problem? What is the danger? Is there any caution?
Patients who are on chemotherapy.
Very good. Which drug?
Irinotecan.
Which one? Irinotecan. Very good. What happens with irinotecan?
There may be more conjugation defects than.
It's not the bilirubin which is a problem with irinotecan. It's a marker of? So the liver is not the problem with irinotecan and Gilbert's. It's a marker of hematological problems. They react very badly to irinotecan. So always warn a patient with Gilbert syndrome, or the oncologist should know that in their choice of drugs not to use irinotecan with Gilbert's. Otherwise there's very little clinical significance. Reassure the patient, just tell them, so this is for you. Gilbert syndrome, reassure the patient not to worry. In fact, the patient is better off than the rest of the population. But tell them if you have chemotherapy, please come back to you. You'll tell them which drugs not to use. If they have anemia, again, it's very simple. Indirect hyperbilirubinemia and anemia is hemolysis. Evaluation of hemolysis is simple because the red cell is the simplest cell in the body. Only three things in the red cell. Membrane, so you have membrane defects, sickle cell anemia, whatever. 2, it has got hemoglobin, so hemoglobinopathies. 3, it's got enzymes, so oxygenation pathway, G6PD and all. So evaluation for hemolytic anemia can be very quick and it's very simple. Or you may have direct hyperbilirubinemia. Direct hyperbilirubinemia, the problem is in the liver. Then you calculate the R value, okay? I want you to understand the R value well. So the R value is a ratio. What we're trying to find out is the AST elevated much more or is the alkaline phosphatase elevated much more? So look at how many times is the ALT elevated. If the ALT is elevated 10 times and the alkaline phosphatase is elevated only once, that ratio is 10. If the AST is elevated 10 times and the alkaline phosphatase is elevated 2 times, then it's 10 divided by 2, so the R value is 5. It just tells you which is elevated much more. So if your R value is more than 5, it tells you AST and ALT are elevated much more than alkaline phosphatase, that is hepatocellular disease. Think of viral hepatitis, drug, autoimmune. R value 2 to 5 times, it's mixed, we'll come into that in a little more. You can get this with alcohol, Viral hepatitis, initially R value is 5, later the alkaline phosphatase goes up, AST and ALT come down, so it's about 2 to 5 times. Autoimmune hepatitis, R value less than 2, so that means alkaline phosphatase has gone up, AST and ALT has not gone up that much. Think of biliary obstruction, think of infiltrative disease, and as you heard, based on the systemic symptoms, maybe this is infiltrative liver disease, maybe sepsis. That is the R value of less than 2. So I have 2 minutes left, so we won't go over this. Let me just, finally what you need to know is the pattern of liver injury in patients with, okay. So finally, this is how, look at how the elevation of the AST and ALT was. Ischemic hepatitis, peak 24 hours, 5,000, 10,000. 3 to 5 days later, it's coming down because that's the half-life of AST and ALT. And by about 7 days, it's coming closer to 2 times from the baseline. What's the difference between ischemic hepatitis and stones? Elevation. Ankur, do you want to? With stones, you get the same pattern. It goes up very quickly. That was the point in the previous case.
In ischemic hepatitis, the enzymes are very high.
Good. So the difference is only, correct. The only difference is the height of the enzymes. So, and then the clinical setting is with gallstones, you have pain. So pain, sudden increase, 1,000, 2,000, usually not more. That is stone disease. But if the increase is more gradual, that is typically viral hepatitis or drug-induced hepatitis, okay? So that is how you approach AST, ALT, alkaline phosphatase, and bilirubin. And now we have a few minutes for questions? Okay, questions now. Or comments? Comments from the chairs or from the panel on liver tests? What do you see commonly which we have not spoken of, which you can tell them? Other things to think of in these?
Sir, one thing, the raised alkaline phosphatase. So if the ultrasound shows no biliary dilatation and AMA is positive and clinical history is compatible, so is liver biopsy is must or we diagnose a PBC?
Yes, good. So that's a good question there. So the question is, AMA is positive, alkaline phosphatase is elevated, do you have to do a biopsy? So for diagnosis, you do not have to do the biopsy. It is only for staging of disease which impacts prognosis, then you will do the biopsy. But if you want to treat without a biopsy, I think that's quite reasonable. How accurate is FibroScan or MRE in these patients? We don't know because it's just, you need thousands of patients before you come up with clear numbers for the staging. So it's only for prognosis, not for diagnosis. And not to decide about treatment either.
I think I just want to echo what Arka said, that in our country, I think tropical infections is a very important differential diagnosis whenever we see acute viral hepatitis-like picture. So I think malaria, enteric fever, dengue, leptospirosis, they have to be excluded.
Yeah, and
I think one more thing maybe at the physicians which is important would be, again, the clinical setting obviously is very important. So what we probably have not discussed today is a young female with some autoimmune disease, say rheumatological disorder, coming with chronic elevation of liver enzymes, autoimmune hepatitis. That's very, very frequently, I think, seen. And similarly, I think the point he raised, if the middle-aged lady coming with chronic cholestatic symptoms, and even if the AMA is negative and ALK phos is elevated, our threshold for thinking about a primary cholestatic liver disease would still go high. I think so. Clinical setting would be very, very important in that.
And then you would consider the biopsy.
Yes, yes.
So that's and these infections. And I know I didn't write many papers when I was in St. John's, but one of the things that we looked at was enteric fever with the AST and ALT going up, and we looked at some differences between the two. I know Harshada's papers on malaria and chikungunya valley fever, those again I elevated. And the study from Africa, from Reunion Island, showed chikungunya was 10,000 AST/ALT elevation. So yes, there are unusual causes.
Yeah, two queries. One is ischemic hepatitis, you mentioned, third day enzymes are normal. However, if the cause of ischemic hepatitis continues, ischemic hepatitis can lead to some other cause. If the cause continues, the enzymes will not come down. And second question is, many patients we see ulcerative colitis, raised alk-phos. However, ultrasound liver is normal. But when we do liver biopsy, it comes small duct PSC. So I say, if alk-phos is elevated, no hepatic parenchymal abnormality on ultrasound, AMA negative, do not forget even then small duct PSC.
Yeah. But so, I don't know how many of you see. Do you see PFIC here? So so in the US, I have a family from West Bengal with PFIC 3. So I think a lot of small duct PSC. So PSC, which you're talking about, is fibrosis of the bile ducts, extrahepatic and intrahepatic. So you can see it on MRCP, you can see it on ERCP. Small duct PSC is MRCP looks normal, but the liver biopsy shows typical features of PSC. So I say the diagnosis is small duct PSC if the patient has inflammatory bowel disease. Then I'm convinced this is PSC. If they don't have inflammatory bowel disease and we see changes like small duct PSC, we see vanishing bile ducts, I think that's a different disease. That is a group I look for PFIC in them because I think it is much more. PFIC was seen in Chile and South America, so that tends to be high. I think if someone wants to study it in India, I'm sure there are going to be a lot of families. Like Wilson is very common in India. So that's a different gene. I think PFIC gene, the ABCB4 mutation, I think will be different in India. So we have that family which we are following in there. I think there are 6 of them already who've got it. Oh yes, you were next, correct. Oh good. So the question is elevation of GGT alone. Good question. So GGT is extremely sensitive test. GGT can be from cardiac disease, GGT can be liver disease. What's that? So correct. So we routinely have stopped GGT because it causes a lot of anxiety. You know, you'll see the GGT elevated and they'll show you their chart with circles. My GGT was this much, next day it goes even higher. And there's no good explanation for that. So it's a good marker for fatty liver disease. You know, very early when all the other tests are negative. It's a good marker for cardiac disease when the tests are negative. But otherwise, a generally healthy person, the only use for a GGT is to say that the alkaline phosphatase is of hepatic origin. We don't routinely check GGT. We stopped checking just because of anxiety, and patients have insurance problems. When the GGT is elevated, they say, okay, no insurance or you pay higher. But it's a, oh yes, any slightest, drugs can cause GGT elevation in there. Your question?
Yeah. Sir, serum lactate, serum LDH can help to differentiate ischemic hepatitis from other causes.
Good, very good point. So LDH is extremely sensitive to ischemia. So on the first day, even before AST goes up, the LDH will go up. So normally AST or ALT is higher than LDH. But very early the LDH is higher. So if the LDH has gone the first day along with the AST and the LDH is higher, that is ischemic. Unfortunately, those patients are with the cardiologist. And anytime the cardiologist sees, they'll probably do an echocardiogram, they don't check the LDH. But it's a very good test, you're absolutely right. It's a very good test. Okay.
Since you say that the gamma-glutamyl transferase is a very important marker for differentiating the origin of alkaline phosphatase, whether it's hepatobiliary origin or it's from the bones. That means we can leave doing 5-nucleotidase and 5-nucleotidase enzyme estimation can be forgotten. It may not be done. Only on the basis of this particular gamma glutamyl transpeptidase, it is good enough to say that this alkaline phosphatase is probably because of hepatobiliary origin or maybe of the bone. Because many times we get referrals from the nephrology department and others. You know, they write the alkaline phosphatase is raised.
Yeah. So alkaline phosphatase denotes of hepatic origin 3 ways: 5-nucleotidase, gamma-glutamyl transpeptidase, and isoenzymes. GGT is typically done because it's the cheapest in there. Okay. And I think we have to close now.
I think we close the session here. Thank you, panelists.
Yeah. Thank you.
Can we have everyone on stage for a photograph? So without wasting any time, we move ahead to the second session, which is on alcohol-associated liver disease. And for that session, I would like to call upon the chairpersons, Dr. Professor Anup Saraya, who is a professor and head of the Department of Gastroenterology at All India Institute, New Delhi, and Dr. Ashish Kumar, who is a professor and senior consultant at Institute of Liver, Gastroenterology and Pancreaticobiliary Sciences, Sir Gangaram Hospital, New Delhi. I would request the chairpersons to introduce the panelists for the sessions.
I would like to thank the organizers for giving me this opportunity to be here. And now I'll invite Dr. Neeraj Saraf, who is a Senior Director, Hepatology, Institute of Liver Transplant and Regenerative Medicine, Medanta Hospital, Gurgaon. The next is Dr. Rohit Mehtani. He is Assistant Professor, Department of Hepatology, Amrita Institute of Medical Sciences and Research, Faridabad, and Dr. Ashok Chaudhary, who is Additional Professor, Department of Hepatology, Institute of Liver and Biliary Sciences, New Delhi.
Okay, thank you. There are going to be 2 messages. If you can forget everything I told you, 2 messages for you as general physicians. One is make people drink less and screen for how much they're going to drink. And 2, make sure people lose weight. So if people don't smoke, don't drink, eat healthy and exercise regularly, 90% of what we do is gone. Okay, so focus that, because when they finally reach us, it's often very late. So you have to start this very early. So alcohol damages the liver, and the damage is quite severe. Okay, so the normal hepatocyte will take up ammonia and release urea into the circulation. That's the normal hepatocyte. The normal hepatocyte divides, that is the regenerative capacity of the liver. So there's detoxification, regenerative capacity. So alcohol, viruses damage the liver and the liver cell dies. So ammonia cannot be taken up, and all other waste products will then go into the circulation. And those waste products are what damage the brain, lung, and the liver. Any dead cell stimulates inflammatory cells, so they come from the extracellular matrix. Inflammatory cells will produce inflammatory cytokines. So then inflammatory cytokines also get into the circulation. So you get a systemic inflammatory reaction. Some of the inflammatory cytokines, like histones, inhibit mitosis. So the end result of alcohol injury, this is what's going to happen to the patient when you see the patient. There is no regeneration, there is liver failure, and there is systemic inflammation. So these are the three features of alcohol-related hepatitis. So the typical course of alcohol hepatitis is they get an inflammatory reaction which may be sterile initially, just from damage to the liver cells. But for reasons we won't go into, they get infected as a result of the inflammation, and that again makes the inflammatory reaction worse. And this inflammatory reaction ultimately leads to organ failure, and patients die unless they are reversed, treated, or transplanted. So let's come to a case, and then we'll go into what you will do in primary care. So type 2 diabetes, this is important because you're going to look after type 2 diabetes, heavy alcohol use, abstinent for 4 weeks, jaundice ascites, confusion, febrile, heart rate 102, serum creatinine 2.2, MELD score 27, discriminant function 58. So diagnosis is severe alcohol-related hepatitis. So diagnosis is not a problem. I want to show of hands. When you see this patient, ICU, 1, 2, 3, 4, 5, steroids, 1, 2, okay. GCSF, there's the author of the GCSF paper, I saw him somewhere, okay. Fecal microbiota transplant, alcohol dependence counselor, good. Evaluation for liver transplant, okay. Any comments? How do you manage the patient? Just go down one by one. Say ICU, yes or no. Steroids, yes or no, or why. That way, just go down the line.
So I would admit the patient to the ICU, then start him on medical management. He has evidence of SIRS, probably some infection also. Start IV antibiotics, send the cultures before antibiotics, stabilize him, start nutritional therapy, watch for 2 to 3 days how the trajectory of bilirubin, creatinine is going, and if there is no evidence of sepsis, then maybe consider trial of steroids.
Yeah, I think that's a very good approach because really important in these patients is infection and nutrition. And in a lot of the patients, you're going to have contraindications to steroids. We're going to come back into this. So this is for you. General physicians, how do you assess alcohol use? I think it's important as a screening test for every patient that you see, how much alcohol are they using? How do you assess for alcohol use?
Sir, alcohol use is on the basis of grams as uniform, so then it's the standard drinks. So most commonly used is the whiskey, which is 40% weight by volume. Then the next is the beer, which is 5% or 4% gram weight by volume. So I have calculated the cumulative dose daily, how much grams is coming up, or average weekly how much is coming.
So yes, good. So the WHO definition for drink is 12 grams of alcohol. So all servings are supposed to be 12 grams. Now what I've shown you is Western. There's going to be a little difference from India. So 1 can of beer, 150 milliliters of wine, or 45 milliliters of whiskey, that is 1 drink. Remember one rule. Patients underestimate how much they are drinking. And so the general rule is whatever they tell you they're drinking is probably double. Okay, so remember that one rule. But we'll talk about that in a little more detail again. So Indian liquor has different alcohol levels. So toddy, which is in the south, 5 to 10%. I was surprised to see there are beers in India which are 8 to 11% too. Yes, there are 5% beers, but 8 to 11. In fact, 8% seems to be almost the median beer in India. That's very high. Arak, 33%. Indian-made foreign liquor, 42%, and distilled spirits. Distilled spirits are very regional. So distilled spirits, just this morning I was reading in Manipur, there's a special type of distilled spirits, that alcohol level is very high. So regional, there are different ways, whatever is available, if it's rice, if it's dates, if it's palm, cashew, that is distilled and you get alcohol. So those are called distilled spirits. Those tend to be very high in alcohol in there. And so if you look at what they're drinking, 40 grams in women, 50 to 60 in men, that is a problem. That is going to cause liver disease. So just get some idea about the alcohol use, what they're drinking, and calculate. So what is the best indicator that the patient actually has an alcohol use disorder? Okay, again, we show of hands. If they say, I have more than 5 drinks for 3 days a week, who says this is the best indicator? Need a drink when waking up. Is that the question you're going to ask them? Remember, you're a primary care physician. You don't have a lot of time. So you cannot ask them all the questions. You have to pick one question. So I'm trying to give you one question that you should ask them. Should it be need a drink when waking up? Who says that? Okay. Angry when asked how much you're drinking? 1. Feel the need to cut down drinking? Anyone? Any comments?
If there is any patient takes he takes a binge of alcohol even once, then also he should be evaluated formally by the audit score for a alcohol use disorder.
So okay, so that's a good point. So you're talking about in the audit score, the full audit score.
If there is even a single episode of binge drinking, then the patient should be evaluated formally.
And binge is defined as?
More than 5 drinks in 2 hours.
2 hours for a?
Male.
And for a female?
More than 4 drinks in 2 hours for a female.
And so the alcohol use, the audit score is a long score. And again, we don't have the time. So we are trying to pick one question to ask from the audit score. Which one is that? So among these, only one is part of the audit score. The others are part of the CAGE score.
First one.
No, cut down is part of CAGE score. CAGE score is more specific but not sensitive.
Audit is the first one.
Good. That simple, just ask them one question. Do you have more than 5 drinks, more than 3 days a week? If they have it, 90% of them have an alcohol use disorder. So that's the single one question you should ask in your primary care practice. I think we're still having problems with. Okay. So patients are always very defensive, not always, often very defensive. They don't want to admit how much they're drinking, especially if they come with family members. So there are some ways you try and find out. How do you find out if they're drinking? Don't ask them how much they're drinking. Ask them how much they're buying. It's a good way. How many bottles are you buying per week? That's a more accurate way of knowing how much they're drinking. The questionnaire we spoke about, the audit questionnaire, is better. Audit questionnaire is available in Hindi, I know. So other languages I don't know, so that's something that can be used. When a person is overweight and is drinking, to find out is it overweight which is causing the liver problem, or is it drinking which is causing the liver problem? This is a score my colleagues Winston Dunn and Vijay Shah have come up with. This is available online. You can calculate that. But if your MCV is high, that is much more likely to be alcohol-related liver disease than related to obesity. And then there are some biomarkers, but you don't really need to know about these. These are when you follow patients with liver transplantation. So just ask them how much they're buying. Are you drinking more than 5 at a time? So here is your evaluation as an outpatient.
One more. You ask the wife.
Yes. No, that's a good point. So anytime you want some corroborative evidence from somebody else when they're not drinking, is to take whoever comes with them aside. Yes, you're absolutely right. So this is how outpatient management in primary care. So we're not talking about the hepatitis. Screen for alcohol use the single question, which is more than 5 drinks. We won't go over the details. If it's more than 5 drinks, then they have a problem. Let the alcohol dependence counselor do the full score. If you think they have an alcohol use disorder, those patients have to be screened for liver disease. So get an AST and ALT. If those are high, they need to see an alcohol dependence counselor. That's when you need to refer them to the gastroenterologist. The gastroenterologist will do tests to find out whether there's liver fibrosis or not. And if there's fibrosis, then that patient is not yours anymore. I think the hepatologist has to follow that patient. Then they do the screening endoscopy. But if the hepatologist thinks not much fibrosis here, just alcohol use disorder, AST and ALT, back to you, you will have to see the patient, okay? So this should be your approach. Is that clear? Questions on this? Okay. So let's come back to our patient again. In the panel, will you do a biopsy in these patients? How often will you biopsy patient with alcohol-related hepatitis, and why?
I think most of the times we don't do a biopsy because if it's very obvious on the history, unless the history is doubtful and you're really thinking of an alternative diagnosis or maybe a second diagnosis along with it. Otherwise, we don't.
I agree. So in general, there is no need. I think there are advantages of biopsy, but that's little more towards research and to decide who will respond to treatment. But in general, you don't require a biopsy, and we'll come into how you approach that in a bit. So this patient is diabetic, remember. So let's say you had no infection, no other, what do you think are the contraindications here? Is diabetes a contraindication? Who would not use steroids in diabetes? 1. If they've got a documented infection, more, good. Temperature 38.5, white cell count 14,000. Steroids, contraindication. They've got melena, they come, they said black colored stool, but hemoglobin is okay. Is that a contraindication? Creatinine more than 3. HbA1c positive. Do you want to, what do you think? Which of these, if you had, because you said if they don't have contraindications, you'd use steroids. So which one of these do you think is a contraindication?
So creatinine and melena.
No drop in hemoglobin.
But melena we have to evaluate. If it is melena, then you have to see why it has happened.
Okay, so you want, and if the HbA1c positive?
Documented infection also, creatinine more than 3, okay. Melena, then we'll do an endoscopy. If there are viruses with high risk signs, we'll ban them. After treatment of management of upper GI bleed, we can consider them for steroids.
And diabetes?
No.
Not a contraindication. Yeah, good.
So can I make a comment here?
Yeah.
So in most of the patients who come with alcoholic hepatitis, we generally wait for 48 to 72 hours. If the patient is improving, then we generally do not start steroids in them. And we start only once he's not improving and we have ruled out all these.
Yeah, and so steroids should never be started on the first day. There are some tests that you have to do which we will go over. There are other conditions you have to rule out. So typically it's going to be about 48 hours before you actually consider steroids in these patients. Never to be started on the first day. These are the contraindications. Documented or strongly suspected sepsis, because sometimes your cultures are going to be negative. You cannot document that. Hemodynamically unstable, GI bleed, yes. Just melena, no. Creatinine greater than 3 years, they don't respond well to treatment. If they are on vasopressors, ventilator, again they don't. HCV, viremia, hepatitis B surface antigen positive, again would be a contraindication to steroids. So there are good studies of high-dose steroid therapy in patients with diabetes. So it's not an absolute contraindication. Just remember, watch them very carefully. This is going to be for a period of 4 weeks if they've responded well to treatment. If you can save their life, try and do that. And the diabetes is going to be less of a problem after 4 weeks, but watch them very carefully in here. So there's minimally invasive glucose monitoring if you wanted, mealtime insulins, and most important is anytime you lower the dose of steroids, change the dose, just review the dose of insulin in these patients. Okay, nutrition. You spoke about nutrition. How do you provide nutrition?
If the patient is awake, he's fully conscious and oriented, able to take orally, meet his energy requirements and protein requirements by oral, then oral, otherwise supplement it with the nasogastric feeding.
Good. And how many calories? What about protein?
Usually 30 to 35 kilocalories per kg per day, but not less than 21, and protein 1.5 grams per kg.
Excellent. Remember, there's not much you can do for most patients with alcohol-related hepatitis. They're too sick when they come to you. They've got contraindications to steroid, which is the only drug that we have. What you can do is treat the infection. So look carefully for infection, provide them some nutrition. Those are the most important factors in there. So this is how you'll evaluate. That's why we said first 48 hours, unlikely to be you'll start steroids. So heavy alcohol use, recent onset of jaundice. Lab tests show rapid rise of bilirubin and AST is greater than ALT, typically less than 400. You have to rule out other causes of jaundice. Just because they're drinking doesn't mean the alcohol caused the liver disease. So they can have biliary obstruction. So stones, they have drug-induced liver injury. They can have viral hepatitis. They may have autoimmune hepatitis. If you bleed and you have hypotension, you can get ischemic hepatitis and jaundice, and it's not really alcohol-related hepatitis. So take a good history in these patients. You have to treat the alcohol use disorder, liver-related complications. We won't go over how you rule out all these conditions, but you have to rule these out. And once you know this is alcohol-related hepatitis, you have to treat the alcohol use disorder. Start treating complications, hepatic encephalopathy, infection very important, kidney injury very important. There's GI bleeding and all, but remember infection and kidney injury is a good indicator for how well they're going to do. So again we said typical presentation, definite alcohol history, no potential hepatotoxic in last 3 months. All yes. So it's very clear. They're drinking a lot, the liver tests are elevated, you don't think there's any other cause. That is what you call probable alcohol-associated hepatitis. If you do a biopsy and you confirm, that is called definite alcohol-associated hepatitis. But if they deny alcohol use, which is common, or the liver tests are not quite what you think, AST, ALT may be more than 500, maybe they had hypotension, maybe they use some other drugs, then you must get a liver biopsy before you say this is alcohol-related hepatitis. Otherwise, this is possible alcohol-associated hepatitis. Definite or probable, high MELD score, MADRI greater than 32, prednisolone 40 daily, recheck them after 7 days. If they're doing better, continue treatment for 4 weeks. If they're not doing better, then you have options. Some patients you can do liver transplant. Some you can enter into clinical trials if you have, and sometimes you just say there's probably not much we can do. No transplant, we have no clinical trials, and that's when you discuss with the family what you really want to do. Who responds best to steroids? This is an analysis of all the patients in all the trials where steroids were used. So The line on top, oh, sorry, so the line on top is mortality without steroids, lower line is mortality with steroids. So the difference is the steroid benefit. So dark blue tells you maximum steroid benefit is between MELD score 25 to 39. So no benefit, MELD score below 20. So don't use steroids if it's below 20. Maximum benefit between 25 and 39. Over 50, again, they don't benefit. So patients are really sick, again, don't benefit. And the survival is only at 30 days, but not at 90 or 180 days. Now we come back to these patients. There were no GCSF hands, so we will not go over this here. ICU management. How do you manage these patients in the ICU? What do you do for bleed prophylaxis? What do you do for infection prophylaxis? Which antibiotics do you use? Do you use DVT prophylaxis?
We usually won't do in our scenario for the DVT prophylaxis.
So no DVT prophylaxis?
Yeah. No.
Okay.
PPI is also unless bleed because this patient is having suspected history of melena.
Let's say no melena.
No, then it's no.
Then you don't, okay. Antibiotics?
Antibiotics, usually give thiazidines and cephalosporins, and then you have to see for the clinical response cultures, and that is the only problem. We give prophylactic antibiotic in most of the cases.
No, if I can, so I see this patient is in the ICU, so would you start cephalosporin? An ICU patient, they're very sick, remember.
Yeah, I think 4th generation cephalosporin, piperacillin, tazobactam, these group of drugs we start beginning.
Piperacillin, tazobactam is better, so that's what I was. Cephalosporins, not piperacillin, 4.5 grams, 4 times a day, not with 3.375 dose, okay. Glucose?
Yeah, we have to keep strict control on the diabetes sugar control.
Okay. So this is generally how we approach these patients. Paracentesis, blood cultures, urine cultures, chest x-ray. All this is why it takes 48 hours before we start treatment. So we treat the infection. We treat with, if they're very sick in the ICU, you don't have much time. Remember, from the time a patient hits the ICU till the onset of effective antibiotic treatment, if it is more than 6 hours, the ICU studies are very clearly shown, if it's more than 6 hours, you're going to lose the patient because mortality is lowest when you start it within 3 hours. In fact, if you suspect infection, the moment they come to the emergency room, you have to start the antibiotics and you start it very quickly and very effective. So patients are very sick. Our preference has been vancomycin and meropenem. I know both of them are available here, but you can use whichever choice that you want. My favorite question is for you. Ertapenem and meropenem, I know both are available, both are very good drugs. What does meropenem cover that ertapenem does not? You look like you know the answer. You're waiting to tell me. Anyone? Remember, meropenem is also called apecillin, APE. Meropenem covers Acinetobacter, Pseudomonas, and Enterobacter, which is not covered by ertapenem. So patients are very sick, ertapenem is not good enough, meropenem. Okay, apecillin, remember it's called the apecillin. So if you want good coverage, use meropenem in these patients. But you can use whatever is your prevailing practice. Piperacillin is a good choice. I must say it's a good choice. General measures, fluid resuscitation within 3 hours, paracentesis, improves cardiac function too, aspiration precautions, we use low molecular weight heparin DVT prophylaxis and stress ulcer prophylaxis with PPI. Still hypotensive, norepinephrine, mean arterial pressure less than 60 despite norepinephrine, That is when we consider hydrocortisone. So that's our typical approach to ICU management of these patients. Remember, if you use prophylactic amoxicillin clavulanic acid, this study does not change mortality, so that has not helped too much.
Sir, I think in the Indian scenario, in a cirrhotic with SCLF and multi-organ failure, DBT prophylaxis, I think most of centers we are not giving.
You're not using it, is it? Okay. And what about if patient has acute liver failure?
No, still.
So you don't use DVT prophylaxis at all in the ICU?
Mechanical, like we use DVT pumps, not
so you,
systemic.
Yeah, I mean, if you can just use stockings, that's enough in these patients. That's fair enough. And you don't get good antibiotics available, so be very careful about antibiotics in these patients, and you have to use them very quickly. So back again. Now we're considering transplantation, because I think out of all the choices I gave, most hands went up for transplantation. I personally think only a minority are good candidates for transplant. But anyway, transplantation, do you want?
I think active sepsis would be probably the #1 contraindication.
Okay. And what about social issues? How do you evaluate them as good candidates based on the alcohol use?
Yeah, so I think that's something which I admit lacks in this country as compared to, the US maybe. I think basically there is really no social worker here to assess whether he would go back to drinking. And I think it's so, but we do take an opinion from the psychiatrist, and they do, if possible, question the patient or the family. But yes, that is a little bit of a gray area.
Yeah. So do you have a fixed protocol about what you do? It's just...
So, I mean, for ACLF patient, obviously, I don't think we have a abstinence period. And if he qualifies for a transplant and there is no contraindication, and let's say he has not responded to steroids, we would transplant him.
Yeah. So I think the best protocol is followed only by one center, and that's the French. I think they have got the really good protocol. So the most important for them is their inner circle. That is the resident looking after the patient, the nurse, the intensive care person, hepatologist, and the addiction person. They call that the inner circle. Any one of them says not a good candidate, that's no. They have veto power there. Only after that the surgeon and all come into that, the anesthesiologist. So there have been occasions where the medical student is looking after the patient because they are closest to the patient. When the medical student says no, the transplant surgeon cannot overrule that patient. So they've got an extremely good protocol, and that's why they transplant only 10% of all patients who come in there. I think it's a little more difficult to do this evaluation when you have living donor transplantation. You don't have that much time, and that's difficult. I know the situation in here. And after transplant, what is the program that they need to go into? Is there any fixed program, or to make sure that they're not going to be drinking? Are they monitored?
Yeah, so we have sort of a protocol where we obviously as hepatologists monitor that, and then we have regular visits to the psychiatrist for counseling.
Yeah. Do they have to sign a contract that they won't drink?
No.
No, okay. So that's part of a requirement that they have to sign. You cannot enforce, you cannot bring CRPF to arrest them, but it's a moral
I don't. Any other center, I don't think we have, we don't have a contract.
No contract.
No, yeah. None of us, yeah.
So transplant contraindications for the general public, there's no really hard and fast rule. So this is what we call the art of medicine. So infections, it depends which infection it is. Cholangitis, liver abscess, SPP, 24, 48 hours of antibiotics. We are okay with transplanting because we say when the liver comes out, those infections go away. Bloodstream infections, 24, 48 hours antibiotics, again we are probably okay because the liver is important. But if the source of infection is elsewhere. So if it's a pneumonia, especially hemodynamically unstable, we'll say no to transplant. Single pressors, okay. If they're on multiple pressors, not okay for transplant. ARDS on a ventilator, patients on ventilator, if it's not for encephalopathy, they don't do well in transplant. So when we evaluate patients for transplant, there is surgical issues. How difficult is the transplant going to be? How many previous operations has a patient had? How much portal hypertension is there? So that's the surgical. Next is medical. How many organs are failing? What are the other issues? And third is psychosocial. How good is the candidate psychosocially? So generally we say avoid a combination. Bad surgical risk, bad medical risk. If it's a good psychosocial risk, no transplantation. So generally avoid combinations of risks in these patients. So this is our
Can I
algorithm.
make a comment?
Oh, sure.
Yeah. So in the, can we go back to the previous slide?
I'm having some, let me try, okay?
Okay, anyway, so by bloodstream infection you mean a positive blood culture?
Correct.
Yeah, so I think most of us would not transplant with a positive blood culture.
And no other source. And no other, only
Yeah, no
incidental
other source.
bacteria.
Yeah, because our experience is that, you know, these patients don't do well.
They don't do well,
Yeah.
okay. And typically what is the source of that? Ultimately, where do you think the source is?
A lot of times the lungs.
Oh, you think from the lungs. So negative chest x-rays or negative CT.
Yeah, but if the blood culture is positive, we probably won't until we get a negative culture.
Yeah.
Yeah.
So we call these incidental bloodstream infections. We assume it's from the liver if we don't find any other source. So we are okay with that one.
So we would also wait for if the creatinine is high. Many of these patients have acute kidney injury. If we would wait for that to recover before transplanting.
So here, okay, so these patients will only get the liver and not a combined transplant.
It's very difficult in India to get a
absolutely, with living donor, yeah.
So for these SCLA, particularly for the transplant, we thought of a window period concept. So when they get admitted if sick, then we optimize them in 4 to 7 days period to see in terms of renal, hemodynamics, sensorium, sepsis, and number of organ failures. If it is improving, then we think of going for the transplant. If it is worsening, then the natural history can be known by day 4. So we strategize by day 4 to day 7, not immediately.
So this is from my learning. So your usual period from the time the patient comes till it's transplanted is how long? 5 to 7 days?
Yeah, mostly up to 1 week in case of
Up to
SCLA.
1 week, okay. Yeah, our general feeling is for living donors, they need time to think about it and not be coerced, don't make rush. So we think never less than 2 weeks, and typically we like it 4 to 6 weeks. They have enough time to make those decisions. But again, it's the practice which is available, and we have cadaver transplants too they can get. So our situation is different.
Yeah, I think probably after 2 weeks only, that's what I would say at my center, at least two weeks.
So like, that's what?
Patients who come to a transplant center would have spent 2 to 4 weeks with medical management, then only they are coming to a transplant.
On that, okay.
So one more comment here. So nowadays there's also emerging role of plasma pheresis. Yeah. So we are also trying in some of
So you try that. So this is really what you try. Do whatever medical treatment you want. And if they have non-responded to medical treatment, that's when you consider these patients for a transplant. You do a quick medical and psychosocial evaluation, and then you decide whether the patient is a transplant candidate. Important is the SALT score. You can get some idea about the risk of going back. So the higher the risk, the more carefully they have to be watched post-transplant. So this is how you take the score. And generally, if the score is less than 5, they should be okay for transplant. So SALT less than 5, no psychiatric comorbidity, no other social we can list. If you're not quite sure, see what you can do to correct the situation. But generally, no insight, they don't think alcohol caused their problems, no social support, multiple drug, driving problems, those are the ones we won't list. Then finally, the results of liver transplantation are good. So these are the different studies that have been done. Here is survival post-transplant, done as urgent, and this is those who have been abstinent, usually for about 6 months. So you see, generally they do well. But yes, people go back to drinking in there. The percentage is small, but some people do go back to drinking. So to summarize, severe alcohol-associated hepatitis, treat them. At 7 days, you'll get a good idea how they're going to do. If they're alive and they're not drinking, they will do well long term. If they've got an alcohol relapse, then if they're no alcohol relapse but have not responded, they've got the substantial risk of death, and that's what we are talking about here as candidates for liver transplant. But if they've had an alcohol relapse after they've gotten better, those patients have high risk of death. They're not very good transplant candidates. So short term, target liver injury, long term, target alcohol behavior. So take home messages. Most important, forget everything else I told you about this talk, consider screening all patients for alcohol use. Single question for high risk use, 5 or more drinks regularly. Infection is very common in these patients, so as general physicians, look for infection in these patients. Nutrition is good. Selected patients will benefit from steroid therapy. I think only about 1 in 10 patients whom you see will be a candidate for steroid. Liver transplantation, again, highly selected patients will really do well. But also remember that even when they're transplanted, post-transplant, they could have problems, so watch them carefully after transplant too. Okay, thank you. And you can make any comments, you or the chairs. Any questions?
Somewhere along your talk you did say that about the percentage of patients who would actually go for transplant. And I think it's very difficult to transplant these patients, and probably maybe 10% of them actually end up because of, undergoing transplant because of either sepsis or, worsening renal functions. And then again, donor availability is a major issue, in living donor transplant, finding a suitable donor.
So the comment is only about 10% of these patients are ultimately good candidates for transplant. My way of looking at it is if you're transplanting 25-30% of these patients, then you're probably transplanting people who should not be transplanted. I agree. I think if we're very selective, about 10% is a reasonable number in there. That means you're selecting carefully. More than that, there's a problem, I think, with the selection process.
So alcoholic patients in India is totally different terms. They're very young, 35 to 40 years maximum. They present more severe way. Ascites maybe minimum 70 to 80% will have ascites, and they have like SCLF more than the alcoholic hepatitis per se. So I think, sorry sir.
Yeah, so this is important. So you heard it's younger patient. For us, US, the number one is a young woman. Young women are the highest increase in alcohol-related hepatitis and alcohol-related cirrhosis. Was particularly bad during COVID because they were at home, husbands at home, everyone's drinking. That was a problem there. So it's a problem with younger people. And why is it younger people? Many reasons, but sports events are walked by young people, and alcohol companies sponsor sports events. Cigarette companies used to sponsor sports events till that was stopped. Alcohol companies are. So young people think it's cool to drink, so that's where the younger people start getting into alcohol. You had a question, Ajay?
Yeah, no, just a small comment. I think we discussed this yesterday, that in India, I think as said, most of these SAH or severe alcoholic hepatitis would come as ACLF, and they will come onto these centers mainly for transplant or even for the ICU care into the centers, and may not really go to the general physicians. So my question, maybe you can just clarify on this. For general physicians, those who get, say, moderate alcoholic hepatitis, not fitting into severe alcoholic hepatitis, other than abstinence and maybe multivitamin or thiamine, any role of anti-craving drugs like baclofen and all, and even in severe alcoholic hepatitis, those who start improving, role of anti-craving drugs, and how should they be managing the moderate alcoholic hepatitis? Not the severe one will go to the centers which are, for transplant and others.
Yes, so good. So if we say severe, so we divide alcohol-associated hepatitis as mild if it's less than 11. Mortality is essentially 0 in that group. Severe is over 20. But we're talking about mortality here. So even moderate, people die with moderate hepatitis. So what do you do there? Most important is abstinence from alcohol. That's what you should tell them. We don't have good drugs to use. The problem about drugs for abstinence is that contraindications to these drugs have been liver disease, So that's, baclofen was used, but that's included as a contraindication. We have a study on a camprosate. A camprosate is very good. So I think once our pilot study is over, we're going to have the 9-center trial on using a camprosate. But some drug which you think is safe reduces craving. And I used to like baclofen before because when patients come from far, if they've been drinking and they've been stopped by the police, they have no license. So then they cannot go for the appointments in them. And so in those patients, I typically have used baclofen before. Now we use a camprosate, but now we're using it under protocol.
So we are discussing alcohol abuse in our country. Now alcohol sale is increasing day by day. What is the policy of alcohol sale in your country? Are we in position to stop?
So out of all the questions I've had today, I think that is the most important. How do you decrease alcohol use? So you have to first look at Russia. You remember Boris Yeltsin. When Mikhail Gorbachev was president, he was a teetotaler. Alcohol use dropped in Russia, liver disease dropped in Russia, all the problems related to alcohol decreased. Mikhail Gorbachev was not president, Boris Yeltsin became president. Boris Yeltsin had an alcohol problem. He opened up alcohol sales. In the first 2 years, alcoholic hepatitis skyrocketed in Russia. So we know restricting sales is important. Anything that has been done at the individual level has not worked. Telling kids not to drink has not worked. Only when government has stepped in, it has worked. So in Europe, France and Italy, less liver disease because they have restricted the hours you can actually sell alcohol. In UK, it has gone up because they've expanded the hours you can sell alcohol. They sell it on Sunday. And alcohol is sold in UK as special. So they'll say, okay, potatoes sale, which was before was £1, we'll sell it for 50 cents. So people come in to buy the potatoes, but next to the potatoes they have the alcohol. So we know that sales of other things are associated with alcohol. I think only when the government steps in, it can make a difference, otherwise it's difficult. That's what's been shown universally.
Religious also, sir. Middle East countries.
Yeah. So the comment here is Middle East countries, less alcohol. Yes, I mean that's religious and it's part of a government mandate. But I hope you know there's quite a lot of alcohol use there too. It's just that it's not open. The penalties are very severe for foreigners who drink, not for local people. They have alcohol programs too.
I think we'll have to wind up the session. Yes. So
apart from government, can we control ourselves? Can we pass resolution today that there will be no alcohol served today evening?
So we know liver disease, the two biggest killers now after viral hepatitis are alcohol and obesity. Both are related to what we do to ourselves, and it's been very difficult to try and change that. We are not very good people, you know that. We will drink and we will eat too much. Thank you. Photo.
Thank you, everyone. And we move ahead to the next session, which is a talk by Sir. And I will request Dr. Ashish Kumar Sir to stay back on stage. And I also request Professor Yogesh Chawla Sir, who is the ex-director of PGI Chandigarh and currently the Chairman Academics and Professor Emeritus at Kalinga Institute of Medical Sciences, Bhubaneswar, Orissa.
Yes, after some very interesting discussions on abnormal liver tests and alcohol-associated liver disease, this is going to be a talk, and he's going to speak to us on approach to incidental liver SOLs. Patrick, the floor is yours.
Thank you so much, Yogesh. So, I'm going to show you some images, but you're going to get these reports when you send patients. And so reports, think of it as three categories. There are benign lesions. Those are the ones I want you to recognize. No further intervention, don't refer them to anyone. There are some which require further intervention, refer them to a hepatologist. And there are malignant lesions, you have to refer them to multiple people. So those are the three categories. Question always is, should you biopsy a lesion? Just ask yourself one question. Is it going to change management or not? If it's not going to change management, don't biopsy. It changes management if you're not sure of the diagnosis on the imaging, then you will take a biopsy. If you're going to change your management or if the prognosis, then you may want to biopsy. But remember, biopsies of malignant lesions have risks. There's hemorrhage and patients can die. You can get tumor seeding along the needle track. But I think very important is false negative. You have to make sure whoever biopsied the right area, because what you don't want is to tell the patient you don't have cancer, go home, when actually the biopsy missed the cancer. So that's the danger of biopsy, the false negatives. So the images that are carried out are ultrasound, CT scan, MRIs. Ultrasound always first, cheapest. And this is the approach. Ultrasound can be a solid mass, which is hyperechoic. So hyperechoic means a lot of echoes. Echoes means there's an interface. That means the density is different at different points. Hypoechoic means no interface, same density throughout the mass. So you can see here, hyperechoic is brighter. I'm not getting the light. See here, it's brighter. Hypoechoic is darker. And calcified doesn't let sound go through, so you get a shadow. And then you get cystic, which means it's filled with fluid. So, hyperechoic mass. Don't worry about hyperechoic masses in general. Cavernous hemangiomas are blood vessels, lot of interfaces, so they get hyperechoic. Fat, fibrous tissue and fluid, lot of interfaces, so hyperechoic. But be worried about metastases. So let's go over this again. This is hyperechoic. Hyperechoic means brighter than the rest of the liver. Hyperechoic. This is hyperechoic, but look carefully, you'll see a rim here. That is called the halo sign or the target sign. That is metastases. So halo is bad with hyperechoic, no halo, not bad. Hypoechoic, always be worried about hypoechoic. They tend to be solid masses, pancreas, lung, breast metastases. Initially in hepatocellular carcinoma, when it's small, it's hypoechoic, then it gets a lot of blood vessels, tends to get hyperechoic. And lymphoma. If the radiologist tells you, I see a big hypoechoic mass, single big, think lymphoma in there. So to summarize, just look at the report. If they say hypoechoic is bad, you need help, call someone. Hyperechoic, no cirrhosis, not bad. It means it's fat or a hemangioma. But if they have cirrhosis and hyperechoic, you have to be worried. That's bad because it might be hepatocellular cancer. Hyperechoic with a halo, bad again. That is metastatic disease. Next we go to CT scans. There's no contrast. There's an arterial phase, a venous phase, and I'll show you why this is important. Because normal hepatic parenchyma gets its blood during the portal venous phase. So it's white in the portal venous phase. And then there's a delayed hepatobiliary phase where again the hepatic parenchyma gets to be white. So, according to the phase, that's why it's important. In the arterial phase, something becomes white. That means it's a lesion which is getting arterial blood, so hepatocellular carcinoma, hemangioma, focal nodular hyperplasia, or an adenoma. Gets bright in the arterial phase. Portal phase, I told you, normal liver is white. So everything that is not normal liver will show up as dark. So that is typically metastases will show up as dark, cysts will show up as dark, abscesses will again show up as dark in the portal venous phase. And then you have the delayed phase. In the delayed phase it can be dark, but if you see it bright in the delayed phase, and I know cholangiocarcinoma is common here, delayed brightness because fibrous tissue retains contrast for a long time. Cholangiocarcinoma tends to be a sclerotic lesion, so you'll get delayed whiteness. So hepatocellular carcinoma, arterial phase will look bright. Cholangiocarcinoma in the delayed phase will look bright. So for you, only 4 lesions that you need to be worried about, that you need to know and not be worried about. Cavernous hemangioma is the first. It's very common, more common in females, multicentric. My general rule, lesions in men, be more worried than lesions in women because focal nodular hyperplasia, hemangioma is more common in women. No risk of rupture or Milligren transformation. So hemangiomas, don't worry about them. So this is the typical picture of hemangiomas. They fill in from the outside and go to the inside, and they are always the same color as blood. So when there's no contrast, that is the IVC aorta, you see same color. Once you get blood in there, you start seeing the same color. It fills in from the outside and the blood moves towards the center. So on MRI, where you can keep scanning them, see how it slowly fills in from the outside and in delayed fills in towards the center. If you've got this picture, you can swear this is a hemangioma, you don't need to do anything further. How do you manage hemangiomas? Nothing. If they're asymptomatic, leave them alone. Surgical resection, you may require some time based on the pressure symptoms. They can get pain, sometimes disabling, then you might consider surgery. Sometimes you're not sure about the diagnosis. Then I think it's better to get that removed. So then you would consider surgery again. And then the Kasabak-Merritt syndrome, if anyone looks after children, Kasabak-Merritt is more in children, but you can get it in adults. Large hemangiomas cause thrombocytopenia and hemolytic anemias. So if you see a hemangioma, platelet count dropping, hemoglobin dropping, that's a consideration for surgery. Otherwise, hemangiomas, just leave them alone. Next, focal nodular hyperplasia, more common in women. Again, multiple. So hemangios in women, FNH in women can be multiple. Focal nodular hyperplasia is absolutely normal liver. It's just that there is more liver in that area, in that focus, and there's increased vascularity. So think of FNH in any patient who has another vascular problem. You will start seeing liver masses in these patients. So MRI is very good for this. Gadoxetate is specific for the liver. So this will show normal liver. So normal liver will be white with gadoxetate. So you can see in the arterial phase, it's white. But as we go into the delayed phase, there's absolutely no difference between this and the rest of the liver. This is classic for FNH. Other features are it tends to have a scar and a lead vessel, which we won't show here. So bright in the arterial phase, iso-intense portal vein phase, because I told you, portal vein phase, normal liver is supplied, so this looks white. Delayed phase, normal liver, again looks white. The closest differential diagnosis in women is in adenoma. So here is where the MRI gadoxetate is again important. Bright initially in the arterial phase, but this is not normal liver. This is neoplastic. So you see in the delayed phase, it's black, because only normal liver is white. So delayed phase, if you read a report to say it's dark, it's bad. It's not normal liver. Okay? So that's an adenoma. You're going to have problems in adenomas in men who are taking anabolic steroids. Last night I heard bodybuilders, gym people are prescribing androgens, and they can cause adenomas, especially in men. So if you have an FNH, will it grow? Minimal, don't worry. Malignant potential, no. FNH, don't become malignant. No need to stop oral contraceptives. No need to follow up imaging. No need to biopsy if you're sure. If the imaging is like this, no need for biopsy, and pregnancy is also okay with FNH. Simple cysts, you are going to see a lot of simple cysts. Thin-walled, and ultrasound is really the best. So it's fluid, same characteristics throughout, so no internal echoes. And because fluid doesn't stop sound waves, rest of the liver is stopping sound waves, so you can see bright sound waves going through. Very typical of cysts. And Doppler, there's no blood flow. So again, you're sure this is not tumor. So this is the approach. Find out, is it simple or complex? Complex will have septae, a thick wall, or will have nodules. Always be worried about complex cysts. So this is the approach. Thin wall, smooth lining, no septae, that's a simple cyst. No to any of these, that's a complex cyst. Simple cyst, no symptoms, leave them alone. No need to follow up image. If they have symptoms, you're never sure whether it causes symptoms or not. If you're fairly confident, aspirate or consider surgery. If you're not sure whether the cyst was causing symptoms, just aspirate the cyst. Pain goes away. When the cyst comes back, pain returns, then you're more convinced that cyst caused the problem. That's when you consider surgery. But if you aspirated the cyst and the pain continued, then it's not from the cyst, leave that cyst alone. Complex, you are going to see with fever, that's an infection. So it's pyogenic abscess, amoebic abscess, actinomyces, infected hydatid. All this is medical treatment. Aspirate, get cultures or do whatever test that you need, and you treat that. But complex cysts without fever, be worried, it is neoplastic. Okay, there are different types of tumors which you don't need to worry about, but be worried about complex cysts in patients without fever. Ask a surgeon to see these patients, or at least consider biopsy of this. Focal fat, problem again with obese population. You can see here patient referred as having gallbladder cancer. Looks worrisome, all this black, but can you see here? It's bright, it's hyperechoic, so that is fat. This sequence shows up fat. You can see all the fat planes become, so this is called out of phase. So you can see that's black, so that's fat, that's not tumor. And with weight loss, everything gone. So you will see focal fat in these patients. So remember, you're going to see this common, and if any one of you is doing oncology, you will see this following agents used in chemotherapy. But overweight and diabetes people will have focal fat. Benign lesions, we spoke about the hepatic adenoma. Be worried about hepatic adenomas. No pregnancy in these patients if the adenoma is big, because they can rupture and the patients can get into shock. If they are on oral contraceptives and you stop them, these can decrease in size. Risk of malignancies, most when they're more than 5 centimeters, that's when you consider surgery. And I showed you this picture again. Reminder, in the delayed phase, it is going to be dark. Last of all, malignant lesions requiring appropriate therapy. Hepatocellular carcinoma is the one that you have to be careful about here. Patient has cirrhosis and you find a mass diagnosis as HCC. When you've ruled out HCC, the next diagnosis you consider is HCC. Consider HCC again. You have to be very sure it is not HCC before you say it's a regenerative nodule. And why does it show up on arterial phase? The normal liver parenchyma gets blood from the portal vein, but tumors, hepatocellular carcinoma, gets blood from the arteries. So the bigger it grows, more arterial flow and less portal flow. So in the portal phase, it'll look dark. So this is the typical picture. It is bright on an arterial phase. Portal phase, normal liver is getting white, but this is not normal liver, not getting portal blood, so you'll see it dark. It's called a washout, which is not truly the right term. And in the delayed phase again, it's not normal, so you're seeing it as dark. So take-home messages. Know for the evaluation if it's a cavernous hemangioma. Be worried if they say it's a cavernous hemangioma in a patient with cirrhosis. But without cirrhosis, say cavernous hemangioma, no worry. Focal nodular hyperplasia, no worry. Asymptomatic simple cyst, no further evaluation. Focal fat, no evaluation. Everything else, please send to somebody else to evaluate further. Okay, thank you.
Any questions from the audience? Any clarifications? What we need to realize is that a diagnosis of HCC in cirrhosis, one has to do a triple phase CT scan or a dynamic MRI to come to a conclusion. And diagnosis of HCC is not through a biopsy, but it's a radiological diagnosis. Alpha-fetoprotein would always help you in these space-occupying lesions. And one usual confusion that we always have of a hypervascular tumor is a neuroendocrinal tumor. So that one has to be aware. The liver, however, would be non-cirrhotic, but these days we get a lot of cases of neuroendocrine tumor.
So the 2 points important. Hepatocellular carcinoma is the only condition, only cancer which is diagnosed in imaging, not on biopsy. Biopsy can be misleading in these patients. Neuroendocrine tumors. So if the radiologist tells you liver is filled with multiple hypervascular masses and the patient is looking perfectly okay, think neuroendocrine tumors. Otherwise, hypervascular metastases can be breast, thyroid, lung, renal cell carcinomas. But generally those, when they metastasize to the liver and it's extensive, patient looks very sick. If the patient looks well, think neuroendocrine tumor.
One question. If the patient is asymptomatic and has hydatid cysts, how do you manage this?
So it's probably, I'm not the best patient. I haven't seen hydatid cyst for 30 years. I'm not. But I have an opinion, but I'm not actually doing it. Who is seeing hydatid cyst here? Some of you have to be seeing. So there's a two type, the hydatid cyst, the one that you get from the mountain sheep in Switzerland and Austria, they tend to be very sclerosing and they can present and look exactly like a cholangiocarcinoma, and those are best resected even if it is asymptomatic. I think the best treatment for hydatid cyst now is medical treatment, and it's albendazole long term. I think that's my opinion, but have I actually treated a patient like this? No, I don't see it. You all must have seen, what do you do? Kaushal?
Medical treatment only.
Yeah, I think medical treatment is.
Although it is touted as a treatment of choice, but most of the time we get away with medical treatment.
I agree. I think it's safe, it's effective, and I think you can do it long term.
Yeah, two queries. Asymptomatic hemangioma, but large size.
Yeah.
Will you do, any non-surgical treatment or not? And second thing is, most important, you see SOL on the ultrasound in the liver. AFP raised, however, triple phase CT is normal. And second situation is SOL on ultrasound in the liver, and AFP is normal, however, triple phase CT is suggestive. In these two cases, will you like to have tissue diagnosis before going ahead or not?
Yeah. So two points there, Rajesh. One is the hemangiomas. So asymptomatic hemangioma, irrespective of size, we don't recommend treatment unless they're symptomatic. But there's a bit of a problem with that, because typically what happens is someone sees this big hemangioma and tells the patient, you have a big hemangioma, please go to another center, it needs to be removed. When the patient then comes to you, they are pressing the abdomen 50 times a minute, and then they're saying, I have pain. So did the hemangioma cause the pain, or did someone telling them they have a hemangioma cause the pain? That is difficult, and that tends to be a problem. The bigger the hemangioma, the more worried the referring physician is. But size alone is not an indication, because it's very low pressure. Look how slowly it fills up. So the risk of rupture is very low. The blood vessels are not under high pressure. But if it's pressing on something causing symptoms, Kasabak merit, yes. The answer to your other question, so if ultrasound and CT, and let's just say we went even further in MRI, so you see a mass on one, at the end of that, it's still indeterminate. You still don't know what it is, that's when you biopsy.
No, my question is, as well on ultrasound, AFP is raised, alpha-fetoprotein, I will say 5 times raised.
Yeah.
However, triple phase CT is negative, not suggestive. Will you not like to do a biopsy or some further investigation in that? I mean, will you like to establish either HCC or not based on tissue diagnosis or not? That is the one indication of biopsy in these patients, I think.
Absolutely. So, this situation is not very uncommon, that alpha-fetoprotein is rising and your imaging is not showing this. So this is typically the infiltrative type of hepatocellular carcinomas, which are not picked up well on imaging. yes, that's when you will consider a biopsy. Clearly, the difficulty is where do you biopsy with infiltrate if you don't know. Some suggest that you do a hepatic angiogram. It's actually better in these situations, make a diagnosis. But current recommendation is you cannot transplant based on alpha-fetoprotein elevation alone.
No, I mean,
yeah.
if confirmed by biopsy.
Fine, Brijesh, I think we've got to wind up. Ajay.
Great as usual.
Ajay.
Day-to-day clinical practice, regenerative nodule always creates a problem. And in a cirrhotic liver, alpha-fetoprotein, say around 15-20, liver is cirrhotic, multiple regenerative nodules. I mean, that's one condition where quite often one has to do a biopsy. And what is your opinion? What is your approach on that?
Yeah, so then that will then be characterized as an indeterminate nodule growing in size, has to be biopsied, because then you will biopsy it. That there's no doubt, you should.
Okay, I think we need to wind up now. Thank you very much, Patrick, for such an excellent talk, and I'm sure the audience would have liked it also. Thank you.
We have a photograph, please, and with this, we also break for tea and coffee, but we are back in sharp 15 minutes. Yes. So again, another reminder, sir has to leave and he would be stopping his lectures at 9. So be sure that you are strictly back in 15 minutes.
Good evening, everyone. After an energizing coffee break, I would request everyone to be back to their seats for the next session. The next session is on non-alcoholic fatty liver disease, and I would like to invite on stage the chairpersons for this session. The chairpersons for this session are Professor S.K. Sareen, the chairpersons for the third session are Professor S.K. Sareen. Sir is the Director of Institute of Liver and Biliary Sciences, New Delhi. Dr. Ajay Duseja, who is the Professor and Head of Department of Hepatology, PGI Chandigarh. And Professor Bhaskar Nandi, Sir is the Professor and Head Department of Hepatology at Amrita Hospital, Faridabad. I would request all the chairpersons to please have a seat on the stage.
Hello. So let's start the session. This is on non-alcoholic fatty liver disease, NAFLD, and let me invite the panelists for this session. Dr. Amit Goel, who is Professor and Head, Department of Hepatology at SGPGI Lucknow. Dr. Narendra Chaudhary, who is Senior Consultant Hepatology at Medanta Medicity, Gurgaon. Dr. Arka Dey, who is Assistant Professor at Department of Hepatology, PGI Chandigarh, and Dr. Akash Roy, who is again Consultant Hepatologist at Apollo Multispecialty Hospital, Kolkata. Over to you, sir.
Oh, yeah. Thank you so much. Thank you, Jay. Thank you, Shiv, for staying. Thank you, Bhaskar. So, non-alcoholic fatty liver disease, I'm giving you only figures from the US. Only about 4% of all non-alcoholic fatty liver disease is managed or sees a hepatologist. Most of them are actually with endocrinologists. So it's a multi-system disease. So in general practice, you're likely to see a lot of these patients. So some of the slides I'm going to show you are from my colleague Alina Allen. I have to acknowledge her. She's doing a lot of the epidemiological work in NAFLD. Okay. So, question, should this patient be screened for NAFLD? 76-year-old male, 188 centimeters, weighs 109 kgs, LDL cholesterol 140, BMI 30.8, likes to eat McDonald's burgers. Who says should be screened for NAFLD? Okay, I think you should tell the patient that. Okay? That is, so NAFLD is less than 5% of hepatocytes. If they have macrovesicular fat is okay. More than 5% is fatty liver, and you have to rule out all other causes of fatty liver here. So no alcohol, drugs, and more than 5%. So in this talk, I think this is very important to you. You should know who should be screened for NAFLD, especially fibrosis, which markers you should use, role of elastography, what are the consequences of NAFLD, what's the role of weight loss, diet and exercise, surgery, endoscopy, and then some take-home messages, okay? So people are very scared they'll be killed by sharks. They're not so scared of eating. So sharks attack and kill 10 humans per year worldwide. Burgers attack 116 million people on any single day in the US alone. Now the global burden of NAFLD, what percentage? 15, hence 20, 25% global, 30, panel. We have to be quick today, so good. So now currently we think it's 30%. I know Ajay told me it's probably even higher here. Okay, so it is a problem. So you have to know about it. A lot of reasons for it. Fast food culture is probably one of those. So this is in the US. Every 15 hours there's a new McDonald's which opens. 160,000 fast foods. Any fast food meal in most restaurants gives you more calories than you need for the whole day. And you have to exercise a lot to get rid of that. Not much vegetables. So once you get into fast food, you're not getting fresh vegetables in there. And most children in America recognize a McDonald's before they speak. So why do I talk about this? Because this is the WHO and ICMR report. Non-communicable diseases in India is the fastest rising of any country. Non-communicable diseases, diabetes, obesity, mental problems, alcohol use. And look how much it costs. Okay, it's much more than the budget. This is budget from 2 weeks ago. I took this number from 2 weeks ago. And this is how much it is actually going to cost to treat obesity. And I was very happy to hear last night that there's a national program, because globally, among all countries, public policy for obesity, I think India is at the top. Let's take obesity in India. Again, these numbers are probably incorrect. This I got again from the ICMR site. Andhra, Nicobar, Puducherry and Sikkim, more than 30% obesity in there. And childhood obesity, which is the big problem. And again, the numbers are probably lower than the actual numbers. Number 1 in the world is US, number 2 is China, number 3 is India. So obesity in adults is high, childhood obesity rising rapidly. And we have what's called the YY, this is a Lancet paper, paradox. Both are Ys. That's their last name. Identical BMI. 21% fat in the Indian, Westerner 9%. So for the same BMI, Indians have more fat than Westerners. So what is the risk of NAFLD? It's most rapid rise among all countries for non-communicable diseases, including obesity complications. For the same BMI, more fat, we have less muscle than Westerners. Insulin resistance at lower BMIs than the West. And so in the future, there's going to be a huge increase in disease and socioeconomic burden in the future. So you have to know about NAFLD. Remember I said most NAFLD is not seen by hepatologists, is going to be seen by you. So who should be screened for NAFLD? Do you want to comment? Whom would you screen? We're looking for fibrosis. That is the big problem that we have. So which of these would, just say A, B, C or D. We don't have time for a long discussion.
All diabetics, irrespective of ALT and BMI.
Good. All diabetics, that's very good. So when you have diabetics, screen them for hepatic fibrosis. So who should be screened? Type 2 diabetes, medically complicated obesity, NAFLD with alcohol use. Someone asked me the question in there about how much alcohol can an obese patient drink. The answer is no alcohol. When they ask you, can we drink? I say yes if you lose weight, but even when you drink, drink as little as possible. And first degree relative of a patient with cirrhosis due to NAFLD or NASH, because all these have a higher prevalence of hepatic fibrosis. Okay, so think about this. Take home message, diabetes. So there are certain conditions which are associated with fatty liver disease here. We're not talking about NASH, fatty liver disease. Do you want to answer this? Which of these is associated with fatty liver disease?
PCOD.
Maybe somebody else? Maybe somebody else? Okay, endoscopist.
It is polycystic ovarian disease, chronic kidney disease, and coronary artery disease. All three are associated.
So, all of them. Good. Yeah. All these are associated with NAFLD. Okay? So, once you know patient has NAFLD, the question is you want to find out whether they have fibrosis. So, which markers should be used? Why do you want to know about fibrosis? Because if they have very little fibrosis, mortality rate is low. So higher the fibrosis, higher the mortality rate. So in general, fibrosis 0 or 1, they're going to die of non-liver disease. More the fibrosis, higher the risk of dying of liver disease. So the goal here is to find out who is at risk for greater than stage 2 fibrosis, 2 or greater. So you can use serum biomarkers or you can use imaging, and typically they can be used sequentially. So there are multiple serum biomarkers used. I like the cheap ones. These are all commercial. They're not that much better, and I'll show you why. So the FIB4, which is age, AST, ALT, and platelets, is actually quite good. You don't have to spend any extra money to get this. These, you start paying more money. APRI, again, you don't pay money. This doesn't have age, but it's not as good as FIB4. So FIB4 is a good, cheap screening test for hepatic fibrosis. So generally, and I know Ajay told me the guidelines are a little different here. We recommend if FIB4 is greater than 1.3, do something else to exclude advanced fibrosis. For you, the message is if it's more than 1, you do that. That's correct, Ajay? 1? No. So now you think that the patient has fibrosis, you want to confirm it. So what is the role of elastography? So, unlike other things, I showed you tumors, blood vessels, all of them have a signature on radiology, but fibrosis has no signature. You cannot look in the X-ray and say that is fibrosis. So, all testing for fibrosis is measured indirectly, and you use stiffness as a surrogate for fibrosis. So, the stiffer the object, you assume there is more fibrosis. Not always true. Most commonly used is transient elastography, but I want you to look at this here. It's most accurate if it's 2.5 centimeters, so obese patient ascites is a problem. Second, 4 centimeters by 1 centimeter, so the volume of liver tissue is about 8 to 10 milliliters. So it's about 100 times what you get on a liver biopsy, but not as much as MRE. And you have different values here, normal, fibrosis, and cirrhosis. You can go even further, and Shiv is one of the organizers of, one of the main people of this Boveno meeting, and the rules of 5 come out from there. You don't have to remember this. 5 is normal. 5 to 10, yes, there is some fibrosis, but unlikely they will have complications of cirrhosis. Over 10, yes, they may have it. Higher it goes, much more likely. And if you have low platelets, again, much more likely. So use a combination of fibrosis and platelets to determine how likely they're going to have complications, and you can also decide about endoscopy, okay? So generally, over 15, it's going to be a problem. Less than 10, not going to be a problem, okay? Then there's MR elastography. MR is the same as this. So you can see this is what we call, this is the active driver. So sound waves go from here and it's placed over the liver. And these are waves which go through the liver. So stiffer the liver, faster the sound waves go. Soft liver, sound waves don't go rapidly. And then you come up with a scan like this: violet, indigo, blue, green, yellow, orange, red. Violet, indigo, blue is a soft liver, get into greens, little more stiff, orange and red, very stiff. Okay? So this is MR elastography. And the volume here is about 250 milliliters. So FibroScan 10 milliliters, here 250 milliliters. So large volume of liver is being tested. So this is how you interpret the results. Less than 2.9, normal, no biopsy. 3 to 4.9, if they are in studies, you may require a biopsy. If it's greater than 5 and you're quite suspicious the patient has cirrhosis, is different from when you are not suspecting cirrhosis at all, you send them from an MRE and it's greater than 5. So we know MRE is not perfect in these patients, we will consider a biopsy. But if you're suspecting cirrhosis and it's greater than 5, this confirms your diagnosis and you don't need a biopsy. Important to know that all these tests have problems. So, not fasting, cholestatic disease, patient is jaundiced, obese, alcohol, inexperience, cardiac disease, all of these will cause falsely elevated. So be careful about interpretation, make sure it is actually done well. Now this is for you. When you see a patient with fatty liver disease, patients are always worried something bad is going to happen to the liver. But they are much more likely to die of non-liver problems. So what is the risk of a non-liver cause of mortality versus liver mortality? Is it 10 times, 20, 30, 40, 50? How many times? It's about 50 times. We'll show you high. They're much more likely to die of cardiac. Once you get fibrosis, which is advanced, then they're going to die of liver disease. But if you start off a patient with fatty liver disease, much more. So that is why it's very important for you to look after these patients well. So this is from my colleague Alina Allen. So this is a 23-year follow-up of more than 5,000 patients. So from the time of NAFLD till they get cirrhosis, median is about 15 years. They spend 4 years in compensated cirrhosis and then get decompensation. So you can see here, they're dying early even before they have cirrhosis of other causes. And we'll go over the other cause in a bit. So you have a 15-year period. So when you see a patient with fatty liver disease, you should tell the patient, my goal here is you never see a hepatologist in your life. So you have to try and prevent them from getting cirrhosis. You have 15 years to do that. Once they get cirrhosis, that come to us, there's not much we can do. We have to improve quality of life and try and change survival. So it's much more in your hands than in our hands, because not only do they have liver problems, they have cardiovascular disease, they are at risk for malignancy, endocrine and neurological outcomes. So this is a huge problem, and of course it's very expensive also to treat these patients. Once they get cirrhosis, keeping them alive is extremely expensive. So the goal here is to prevent. So remember I said 2 messages: alcohol, cut down, weight, ask them to lose weight. So in terms of the burden, it's about 30% of the world will have it. If you look at certain populations, it's much higher. So for you, diabetes, class 3 obesity. Once they have NAFLD, mortality is from cardiovascular events. Once they get NASH, then liver-related mortality tends to go high. And patients who have diabetes with fatty liver or chronic kidney disease again tend to have higher liver-related mortality than those who do not have that. So what's the clinical presentation of these patients? Usually asymptomatic, maybe some right upper quadrant discomfort, some elevation in liver tests. Remember I said over 500 is acute hepatitis, typically less than 500. Alkaline phosphatase may be elevated because some of them get a little hypoxemic too. GGT elevated frequently. Somebody asked me the question on GGT, good marker for fatty liver disease. Bilirubin, albumin, INR tend to be normal. They have metabolic problems. They may have elevated ferritin because fat in the liver decreases hepcidin. And don't be misled. ANA positivity occurs in these patients, so that itself does not mean this is autoimmune hepatitis. These are patients who might require a liver biopsy. So when we look at patients with high BMI, ultrasound normal, the most beneficial therapy in them is not vitamin E, metformin, pioglitazone, or ursodiol. It is weight loss. Focus on weight loss here. So weight loss is your first line of treatment. 30% energy reduction in calories, fruits, vegetables, nuts, whole grains. Decrease refined carbohydrates, sweets. Exercise program, very important. Add some resistance. So exercise 150 minutes per week. No one is sure exactly which exercise is best. Let them do some exercise. Also resistance exercise, muscle helps. So that's a lifestyle modification. Some can have pharmacotherapy or endoscopic treatment or bariatric surgery. This is what you should tell your patient. You lose 3% body weight, you'll start decreasing fat in the liver. You lose 5%, ballooning and inflammation decreases. 7%, NASH starts resolving. And 10%, fibrosis starts resolving. So what are you going to tell your patient? What percentage to lose? I tell them 10%, I'm happy with 5. They're not going to lose 10%. If you tell them 3%, they won't lose weight. So I always tell them 10%. I give them a target. Send me your weights. This is how much I want you to be. So this is the guidance document, and I know there is an INASL guidance document, so I think you should, and I think, Ajay, you can send it to everyone here? Good. So there are no FDA-approved medications in the US. So we don't have medications, but you try and use medications for other reasons which may help NAFLD. So like semaglutide, good for diabetes, good for weight loss, has cardiovascular benefit, and improves NASH. Pioglitazone improves NASH. Consider it for NASH and type 2 diabetes, but I generally have never liked pioglitazone because of the weight gain, congestive heart failure, increased risk of malignancy. Vitamin E improves NASH, but increased risk of bleeding and prostate cancer. But remember, none of the drugs that have been tried have demonstrated that fibrosis regresses. Okay, that I think should be one of the goals in here. Metformin, urso, silymarin are not recommended for use because histologically they've not shown any benefit. Coffee, easy enough. So one, tell your patient to lose weight. 2, coffee, at least 3 cups daily. They have less advanced disease. Whether this is a cause and effect, we don't know. But certainly coffee tastes good. What about bariatric surgery or endoscopic procedures? In patients with cirrhosis, you can do endoscopic procedures. One thing is important now. When you do a weight reduction surgery, you're not doing it for the NAFLD. Proven benefit is decreased cardiovascular risk in the long term. So you're doing it because they're overweight, you want them to lose weight, less cardiovascular problems, and the added benefit is it will work on NASH. And generally in cirrhosis, many of them are not going, if they're compensated, they may not die of liver disease. You're doing it to prevent cardiovascular risk in them. Make sure they don't have portal hypertension. So simple bariatric surgery, NASH cirrhosis, careful, compensated cirrhosis, preserved synthetic liver function, absence of clinically significant portal hypertension, can consider surgery, no significant other comorbidities which will come in the way of surgery, and the results are extremely good. Remember 30, 60, 90. 90% will lose fat, 60% will lose inflammation, 30% will lose fibrosis. So this is the guideline from the US this year. Effectively resolved NAFL and NASH in the majority of patients without cirrhosis and reduces mortality from cardiovascular disease and malignancy. So we're talking about mortality reduction. So take-home messages for today. Non-alcoholic fatty liver disease can be pure steatosis, which is about 75% of patients. About 25% will have inflammation, that is NASH. Among those patients with NASH, some will have fibrosis and some will go on to cirrhosis. That's about 20% of NASH will go on to cirrhosis. So if you look at all patients with NAFLD, only 4% will ultimately get cirrhosis, and even among them, many will die of cardiovascular causes. So this is how we will approach them in primary care. From the risks I told you, diabetes, obese, do a FIB-4. For you it's going to be 1, for it is 1.3. If it is less than 1.3, we are not so worried about the patient. You can continue to follow. If they have diabetes, do this every year. If they don't have diabetes, do it in 2 years. But if it's greater than 1.3, you're worried that this patient might have fibrosis. So you must do something else. So you can do some of the things that I showed you, or there are the serological tests to decide what the risk of fibrosis is here. If you found out that the FIB-3 is greater than 2.67, that's much more likely they have advanced fibrosis. Send to a hepatologist. If the testing here, your second line testing, secondary risk assessment says intermediate or high risk, send them to a hepatologist. If AST and ALT are persistently elevated, you're thinking of some other cause, is this autoimmune disease, again send to a hepatologist. So then what does a hepatologist do? Hepatologist now has the patient, can do more testing, can do an MRE, may consider liver biopsy in some situations. Hepatologist assessment that this is low risk for hepatic fibrosis, back to primary, you will continue to follow the patient. But if the hepatologist thinks intermediate or high risk, may consider liver biopsy in some situations because you're not sure about the diagnosis here. But at the end of this assessment from the hepatologist, it'll be stage 0 or 1 biopsy. These patients don't need to be followed so carefully, can go back to you. But stage 2 to 3, I think they need to be followed carefully by a hepatologist. And if they have got stage 4 or advanced 3-4 clinically significant portal hypertension, then they should have cirrhosis-based management. You often don't require a liver biopsy. If the hepatologist is sure this is cirrhosis, then again it's cirrhosis risk management. Now, wherever the patient is, doesn't matter if the patient is in primary care or with you, don't forget cardiovascular risk reduction, alcohol intake, overweight people should not drink, lifestyle management, make them exercise and lift some weights. So my take-home points, patients with diabetes and metabolic syndrome are at risk of NASH and should be evaluated. FIB-4 can be used as first line to assess risk of hepatic fibrosis. FIB-4 greater than 1.3, but for you greater than 1, consider doing further testing. Mainstay of treatment is weight loss, treat comorbidities, consider drugs that might also help NASH, In the US, we don't have any approved drugs. I know here you have some. And don't forget, don't worry about the patient, you have 3 cups of coffee every day. I have South Indian coffee, which I think is the best. Okay, thank you.
Thank you, Patrick. This was very comprehensive. And I guess if there are 300 people here, 100 of us may have fatty liver. So don't ignore, remember the messages given very clearly, lucidly. I would summarize in my way. The first is the topmost message. Anybody who has a BMI above, I would say 25, but should be 23, or has diabetes, should be screened for fatty liver. We have people who are less than 23 BMI still have fatty liver, but don't confuse. And this is a term called metabolic dysfunction associated fatty liver disease, MAFLD. There may be controversies, but it is simple. Diabetes or BMI above this or metabolic dysfunction is screened. Part 2 is that FIB4 is very easy. You remember, in my opinion, platelet is extremely important. If it goes less than 1,50,000, then start worrying. If it is less than 1,100,000, it is very, very worrisome. So, simple message is platelet, AST, ALT, and age, FIB4. So, most of our hospitals have a calculator. Patient gives a blood, and you had a FIB4 printout, and you can say this guy is high risk or not risky. The third message which I would certainly like to say is a need of liver biopsy. In other areas, biopsy needs have decreased, but if you are between 8 and 12 or 8 and 14, there may be a need for biopsy. Above 14, you know it is likely to be cirrhosis. So fibroscan or elastography is a very important stay. Persistently high AST, ALT are very high. I would have just 1 or 2 messages again from our everyday experience. We are seeing patients at 25, 30, 34 who are not overweight but has full-blown cirrhosis, and they are coming as NAFLD. And you don't have much margin of weight loss. And one question which I have for Pat is about use of metformin. So if there is a patient with diabetes and patient has maybe cirrhosis or advanced fibrosis, which drug would you recommend and treat the patient both for fibrosis and diabetes?
So the question here is, will we use metformin for fibrosis? I recommend to the endocrinologist to use metformin to treat the diabetes with the added benefit for the liver disease. So yes, but we leave it to the endocrinologist to work out the dose. Yeah. So these drugs that I showed you, they are not primarily approved for NAFLD. So if they don't have diabetes, then we don't use it. Yeah. But if diabetes is good, metformin is good. I like statins, I like metformin. They reduce risk of malignancy. They've got other benefits too. So I like those drugs.
So metformin for me also, and for most of us, is the drug of choice if there is diabetes and fibrosis, or even if not diabetes but there is advanced fibrosis. It has insulin resistance reducing, liver cancer reducing properties. And one more question for Patrick would be, if a patient has advanced fibrosis but has no portal hypertension, how much weight reduction can reverse this? There are lots of studies, and I would like him to tell, weight reduction, can it reverse fibrosis? Can it reverse portal hypertension?
So the relationship between weight loss and fibrosis, so it's interesting. So patient has cirrhosis, they exercise regularly, they lose weight, portal pressure decreases. If a patient has cirrhosis and is overweight, higher chance of hepatic decompensation. Overweight patients with cirrhosis, higher chance of decompensation. So clearly there's an association between weight and decompensation. We recommend the 10%. Remember I said 2 things very difficult for people to give up is alcohol and food. You know, these are human behaviors, that's difficult, but we aim for 10%. The bariatric surgery studies that I showed you there, so 10% of weight loss was the best, but with 5% you still get benefit. Was that the point you want me on?
So I think one of the biggest challenges which we have in fatty liver disease is less than 10 or 20% of people actually seek a formal consultation for fatty liver. We recently did a small questionnaire within the hospital where about 200 faculties, non-gastroenterology, and the results were, I think, very obvious. Majority of them, about 80% of them, did not give any cognizance to the ultrasound report showing fatty liver. Yeah. The reasons varied from it does not belong to my specialty, somebody else, or as equal number of people actually didn't realize the clinical impact of a fatty liver disease, that it is progressive. Many of them didn't know that it's a progressive disease. Many of them didn't know that extra hepatic complications, the mortality is higher from them rather than from liver failure. So I think in one way, we as a body, we should take up this to increase the awareness even among the doctors, apart from the community level.
So it's not peculiar to India alone. In the West, it's exactly the same thing. That the awareness of fatty liver disease outside of hepatology is not as high as it should be, especially in endocrinologists. You know, for endocrinologists, essentially diabetes clinic, everyone should be screened. But even at that level, it's not available. So that's why we are hoping now there are 250 physicians in Delhi who will not, you know, we cannot count them. They will all be screening and are aware of fatty liver disease. I hope you know that and screen these populations for fatty liver disease, especially fibrosis.
I think we don't want you to miss the flight, so I think we'll have to wrap up here. But any burning comments from the panelists? Because I'm sorry, I think we can't. We can have questions maybe during dinner hours. Any burning issues?
Sir, I think we need a small comment on the type of coffee we have to consume without milk and sugar to make it more clearer.
So without sugar, without milk.
Yeah.
Without
Otherwise,
milk.
the advantage of the coffee.
So the question is, what sort of coffee? So this is an association, so no one knows what caused it. Maybe coffee drinkers are otherwise healthy and they don't get it. No one knows for sure. The ASLD guideline says caffeinated or decaffeinated. So there are different combinations. With caffeine, without caffeine, with milk, without milk, with sugar, without sugar. So we don't know that. I have my 3 cups of coffee because I like coffee. You know, so when I said my 3 cups, and I have mine with milk, and I have it sweet when I'm in India.
So thank you very much, sir. I think we thank the chairpersons and the panelists, and thank you, sir, for this. You go on to the next session. Thank you all.
I would request all the panelists and the chairpersons for a photograph.
Some say no.
Moving on to our next session, which is on abdominal pain and hepatobiliary diseases, I would like to call on stage the chairpersons for the session. Dr. Ajay Kumar, sir is chairman, gastroenterology and hepatology, PAN-MAX and HOD BLK Institute for Digestive and Liver Disease, New Delhi. Dr. Brajesh Sharma, professor and head Department of Gastroenterology, GV Pant Hospital, New Delhi. And Dr. Manoj Kumar, professor, Department of Hepatology, ILBS at New Delhi.
So, may I invite on stage our panelist, Dr. Piyush Ranjan, who is Senior Consultant at Institute of Liver, Gastroenterology and Pancreatobiliary Sciences at Gangaram Hospital. Dr. Praveen Sharma, who is also a Senior Consultant at Gangaram Hospital. Dr. Praveen, not here. and Dr. B.L. Meena, who is Assistant Professor at Institute of Liver and Biliary Sciences. Sir, please.
So little change in the program. I'm sorry to the panelists, but because we are running short of time, I may not ask you all the questions, okay? So back to hockey, national game. I like hockey, you know that. So we talked about the 24 goals. Who scored the most goals? Are you sure? It was his brother Roop Singh scored. Roop Singh 8, Dhyan Chand 5. Richard Allen was the goalkeeper. So there are many records. 24-1 is a record. 10 goals in a game is a record. Richard Allen, goalkeeper, record. 3 Olympics, only 2 goals were left through as goalkeeper. So remember these records too, in addition to all those million cricket records that you remember. So patient with cirrhosis, we'll talk today only about biliary disease. When they present with right upper quadrant pain, multiple conditions that you can consider. Vascular disease, lung disease, parietal disease, and they get other diseases too. But the focus today is only on gallstones. So acute right upper quadrant pain, here we have a patient woken up early hours of the morning, that is important. Nausea, 3rd episode in 10 days, no fever, MEL24, ascites, gallstones and a thickened gallbladder. What do you want to do? More tests?
More tests in the form of a CT scan, liver functions and creatinine.
Okay, so, and then what are you going to do? How are you going to treat the biliary colic?
Biliary colic in patient with cirrhosis with MELD score of 24. So first I would like to consider the possibility of liver transplantation. Depends on the status of the and possible outcome of the liver disease and cirrhosis. If there is no possibility of liver transplantation in the near future, then we can consider of biliary drainage, maybe endoscopic or radiological in case of minimal ascites.
Perfect, good. So, a colic is a pain which comes and goes, comes and goes, comes and goes. Which are the true colics? Is biliary colic a true colic? Renal? Some nodding for renal. Ureteric? Comes and goes, comes and goes, comes and goes. You're sure? Intestinal? Good. The only true colic is intestinal. The only one which comes and goes. Rest tend to be more steady. Okay? Next thing to remember is there are very few pains where it'll reach peak intensity in minutes, 10 minutes. They'll say I was well, and then I got this pain, and in 10 minutes they are rolling over in pain. So which one of these is it? Duodenal ulcer? Portal vein thrombosis? Small bowel obstruction? Diverticulitis? Hemorrhage into tumor? Okay. So let's get to basics. Really important. Can you see this textbook of surgery? Standard book for surgeons. Newest edition still says this. Modern advances in imaging cannot replace good history and physical examination. So that is very important to me in a patient with abdominal pain. So first question I ask them is, show me where the pain is. If they point with a finger, that is either in the muscle or is peritoneum. If they show me with the hand, that is deep, that is visceral pain. So first ask them, show me where the pain is. Then, the more inflamed, the more severe the pain. If they say the pain was extremely severe in minutes, only for, we are not talking about outside of the gastrointestinal tract, consider only 4 conditions. Either they've perforated, they've had an arterial embolus, which gives them extremely severe pain in a short duration of time, that there's a tumor which has either hemorrhaged or ruptured, so sudden increase in size, and biliary colic, extremely severe pain which goes to maximum in some minutes. So once you get the pain, it worsens over several hours, then you know it's not colic alone, you know it's getting inflamed. Same thing with venous thrombosis. The pain takes time to increase, doesn't reach in minutes. And pain, they say, okay, it was not so bad. I first started in the epigastrium, but then it went around the umbilicus and got very severe. Then you know there's portal vein thrombosis, which has gone into the superior mesenteric vein. Again, location of pain, radiation is important. For definition, radiation is anatomical continuity to the site of pain. Referral is no anatomical continuity with the pain. So you know liver and biliary pain are referred to the right shoulder. Eating is not a very good localizer. If the pain increases with eating, you cannot tell for sure where it's coming from. Look at the patient very carefully when they explain pain, especially in hospital. Ischemic bowel and biliary colic, they're trying to move around, trying to find a comfortable position for pain. But if they're standing, if they're lying down absolutely still, not moving about, that is peritonitis. So just from your history and looking at the patient, you can get a lot. Where is the most common location of biliary colic? Right upper quadrant, epigastrium, lower sternum, left upper quadrant. It's in the epigastric. So it's typically an epigastric pain, okay? Now, what if they have fatty food intolerance? Who says it suggests biliary pain? Anyone? What do you think? Not at all. It's not a good marker of biliary symptoms. So this is what typical biliary colic is. More likely to occur during periods of weight reduction and physical inactivity. If they wake up from sleep, that's a good marker. Reaches intensity over minutes, plateaus for 30 to 60 minutes, and then slowly resolves. Does not resolve and continues, they're getting cholecystitis. It's felt in the epigastrium, less frequently right upper quadrant, left upper quadrant, precordium, or lower abdomen. And fatty food intolerance is not a biliary symptom. And again, biliary colic is not a true colic, it's a steady pain. Examine the patient carefully. I said last night, all the signs we learned on percussion and auscultation don't give you much. Palpation gives you a lot. So there are different signs that we have. One good sign is look for tenderness. And if they contract the muscles and the tenderness increases, that's parietal wall pain. It's not from deep. If the pain decreases on contracting the wall, it is from deep. That is called Carnot sign. Charcot sign you know about. Courvoisier sign you know about, the palpable gallbladder. Ranshoff sign, post-ERCP fair patient. Patient has been taught me lots of done on the biliary tree, comes with severe pain, hospitalized, look around the umbilicus. If you look carefully, you will find it. If you see yellowness around the umbilicus, you know the bile duct has been ruptured. But my favorite sign, it's always been my favorite sign, is Mankoff sign. Anytime I palpate, I put my hand on the pulse and look at the heart rate. If the patient is shouting and screaming and the heart rate has not increased, this is probably not true pain. These are simple things that you can do before you do a lot of tests. Be careful about diagnosing cholecystitis in cirrhosis, because the ultrasound and CT scan will often show you a thickened gallbladder. That is not enough to say this is cholecystitis, because that's part of the portal hypertension and the thickening that occurs. As you heard, delay elective cholecystectomies if the patient is a candidate for liver transplantation. But if urgent surgery is warranted and you're sure about the diagnosis, make sure you're referring to a center with excellence. And you don't recommend cholecystectomy with advanced liver disease. You must consider cholecystostomy in these patients, and the preferred would be an ERCP with gallbladder drainage. So this is from the GI endoscopy. This is from my colleagues in there. So this is a large series in patients mainly with cirrhosis. We are generally recommending 2 stents now rather than 1 stent. Do you use 2? Do you use 2 or 1? 2, yeah. Because we used 2 because those patients seem to do well in the long run. When we did 1, I think 13 patients we had to put in a second stent. So we just want to buy them as much time as possible. When you go in for, when you're considering procedures, if they have ascites, you have to be worried about surgery and you have to be worried about axial stents placement there with ascites. So generally, you can still do cholecystectomy in patients with cirrhosis. Laparoscopic cholecystectomy is if they've got good liver function, you can do it. We always want patients with cirrhosis going for cholecystectomy. A, I want only my very good liver surgeons doing it, not anybody else. And B, normally we say there's about a 1% risk that they'll have to proceed to an open cholecystectomy. In these patients, we say there'll be a, I don't know what happened, 10% risk for, a 5 to 10% risk that they'll go to open. Okay, this is showing something different here, but that's the correct. So, and surgeons will do different things, but open cholecystectomy, the mortality rate then is going to go up in these patients. Now, when you send a patient for surgery, patient will ask, will my pain go away? So there are some predictors of who will benefit with surgery. Because gallstones are common, abdominal pain is common. You want to know, did the stones cause the pain? And if I remove the gallbladder, will the pain go away? So, if the pain has been present for years, more likely to go away with cholecystectomy, show of hands. If it's associated with fatty food, goes away within 24 hours, wakens from sleep. And so this is another large study which has been done, trying to see which patients benefit from cholecystectomy. That is, the symptoms that they had went away. Infrequent pain. If patient says, I have pain all the time, every single day, not likely to benefit from cholecystectomy, maybe something else is happening there. Present for less than a year, episodes last about an hour, severity of pain, very severe pain, I told you. So generally I call it the rules of 1 and 10. Once a month, present for a year, lasting 1 hour, severity of 10, and waking them up at night. These people will do very well with a cholecystectomy. If they have postprandial pain, not a good predictor of response or non-response. That's variable. But predictor of non-response, if they've associated, they say, I feel gassy, bloated, fat intolerance, lower abdominal pain, and they have gallstones, not likely to do well with a cholecystectomy. So take-home message, patient with right upper quadrant pain, this is how we generally recommend the approach. Good history and physical. Repeat good history and physical. Don't go for imaging right away. Do some blood tests. If the blood tests are normal, get an ultrasound. Ultrasound shows gallstones. Good story for biliary colic. Send them for surgery. If they're not good candidates for surgery, do gallbladder drainage. If the ultrasound is normal, liver tests are normal, you're convinced the patient really has pain, then you have to do something else. Either CT scan, MRI, we like CT scans cheaper, quicker, and then you have specific treatment at that time. On the other hand, if the liver tests are elevated, you're a little concerned here. Get your ultrasound, but dilated bile ducts, go for an ERCP in these patients. They need some drainage. And on ERCP, do whatever treatment is required. But the ultrasound shows normal bile ducts. So this is not fitting into any particular pattern. They have pain, liver tests elevated, normal bile ducts on ultrasound. You have to do more imaging here. So that can be a CT or MRI, because now you're worried, does this patient actually have portal vein thrombosis that is causing the pain? And then whatever you find on the CT or MRI, then you have directed treatment. Okay, thank you. So that is biliary column. And maybe comments from, because you're endoscopists too, any comments, questions? And questions from the audience too.
Quick questions from the audience. Maybe the size of stone in this particular patient, if there is a single large stone, maybe you can leave them alone. Maybe if there are small multiple stones, that is another factor which might influence your decision to do or what to do.
So good point, good point. Does the number and size of stones make a difference? Multiple small stones much more likely to be symptomatic than single large stone. However, 2.5 centimeters stone and larger is associated with the risk of gallbladder cancers. So large stones you would like to consider surgery. Multiple stones are more likely to be a cause of the problems than a single stone. Absolutely right.
And sir, in cirrhosis, frequently you might have a problem with portal vein thrombosis. If there is acute portal vein thrombosis, concomitant gallstones, cirrhotics are more likely to have gallstones, 2 times higher risk than the general population. So these things require a more led decision making.
No, you're correct, because portal vein thrombosis can cause some biliary symptoms, but patients with cirrhosis can have gallstones and portal vein thrombosis. These are patients who must be looked after by people with experience, not even just by any gastroenterologist. And the surgeons who deal with them have to know the liver surgery well.
Patrick, excellent presentation. The similar patient with a gallstone, acute cholecystitis, with or without ascites, cirrhotic. What is your comment on US-guided gallbladder drainage vis-a-vis transpapillary drainage?
Yes, so US gallbladder drainage is increasing. It's a good procedure. There are some concerns. So the guidance document has just come out this month on EUS guidance, because there are no guidelines. Guidelines require data, so this is guidance. Contraindication has been ascites, because apposition is a bit of a problem. So ascites, definitely don't do it. The question is, in cirrhosis, would you do it? We have concerns about transplant later. In patients without cirrhosis, who've had EUS guided, even axial stents placed, cholecystectomy has not been a big problem in them, so they can manage. But if you have portal hypertension, increased vascularity, you just don't want to make the job for the transplant surgeon more difficult. So we are very comfortable, very happy with transcystic stent placement. I was saying last night, someone was saying they have difficulty. I must say, I think in the past 4-5 years maybe, I've not had a single patient my colleagues have failed. So I'm extremely comfortable with them, and I think that's safer for the patients, especially if they're transplant patients. But with ascites, don't do the procedure.
Okay, I'm getting the signs from Dr. Ajay. We'll need to close this session. Thank you very much.
request the chairpersons and the panelists for a photograph. For the last session, we have a talk on approach to AKI in patients with cirrhosis. I would like to invite the chairperson for the session, Dr. Rakhi Maiwal. She is Professor, Department of Hepatology at ILBS, New Delhi, and Dr. Arka De, Assistant Professor, Department of Hepatology at PGI, Chandigarh.
Thank you again. This is my last talk, and soon after the talk I have to leave. I have a flight in 3 hours, I'm leaving. So Rakhi is, I know she's very shy and modest, but Rakhi now is recognized internationally as an expert in kidney injury and cirrhosis. So if you have any questions, please feel free to ask Rakhi, okay? So I just have to be very brief here because we don't have much time. What are the causes of acute kidney injury and cirrhosis? Albumin is used a lot. What are the problems with albumin? And finally, how should you approach when you have a patient with acute kidney injury and cirrhosis? So what are the causes? Most people worry about hepatorenal syndrome, but that's not that common. Pre-renal, volume responsive, more than half the patients. Acute tubular necrosis next, they have infection. And HRS, AKI, only about 20% of patients. Post-renal, which means ureteric blockage, very uncommon in these patients. So, why do you get ascites in cirrhosis? So there's increased intrahepatic resistance which causes portal hypertension. The peripheral vessels start dilating. So there's the same amount of blood flowing in a wider space, so that's a decrease in the effective arterial blood volume. So the kidney senses this, and the kidney activates neurohumoral systems, renin, angiotensin and aldosterone, which retains sodium and water, and that gives rise to ascites. With time, the liver disease gets worse. So further systemic arteriolar resistance decreases, more vasodilatation, further decrease in the effective arterial blood volume, more activation of neurohumoral systems, more sodium and water retention, and they get refractory ascites. With the reactivation of the neurohumoral systems, you start getting intense renal vasoconstriction. And that increased renal vasoconstriction gives rise to the hepatorenal syndrome. So, less blood supply, intense renal vasoconstriction. So what can make this worse? This is the pathophysiology. If you use vasodilators, large volume paracentesis, they have infection, they vasodilate more, that decreases the arteriolar resistance. If they have diarrhea, vomiting, bleeding, that decreases the arterial blood volume. That will activate the neurohumoral systems, renal vasoconstriction, renal dysfunction. Also remember non-steroidals. Be very careful. Patient with cirrhosis, be careful of non-steroidals, but you can use, once you have ascites, not even one tablet of non-steroidals because they cause renal vasoconstriction and will go to renal dysfunction. And that is the hepatorenal syndrome. Just remember a few things in general. So, vasodilatation first, decrease in the effective arterial blood volume, activation of neurohumoral systems, which will cause vasoconstriction and retention of water and sodium. And the sodium retention will give you ascites. Renal vasoconstriction will give you hepatorenal syndrome. Water retention will give you hyponatremia. Therefore, besides renal failure, patients are going to have sodium and water retention. So that means if they don't have ascites, it's unlikely to be hepatorenal syndrome. And if they don't have hyponatremia, again unlikely to be hepatorenal syndrome, because these generally go together. So there are many diagnostic criteria. Don't worry about this. What it means is you're not finding cause of kidney injury, so urine microscopic examination is normal. You've replaced volume, so you've taken care of pre-renal, and still the kidney is not better. So kidney is functionally abnormal. That is hepatorenal syndrome, and there are some criteria. And I think, Raki, you are working on your section to put the criteria together, correct? Good. So how do you manage these patients? Basic problem is cirrhosis. So the only effective treatment is liver transplantation. There's a decrease in the effective arterial blood volume, so you can use albumin. You can use vasoconstrictors because for decrease in systemic arteriolar resistance. So treatment is albumin and vasoconstrictors. So we won't talk about vasoconstrictors, we'll talk about albumin, which is used so frequently. Be careful with albumin. Two studies from about 18 months ago, patients with cirrhosis given albumin in hospital, more pulmonary edema or overload. And in the confirmed study, they were probably given too much albumin, again they had pulmonary edema. There is 5% albumin in saline, which replaces volume right away. But when you give 25% albumin, it takes 3 to 5 hours for the volume to expand. And that's usually a time that you're not there. So you write this order for 100 grams, 25%, and you leave. When you come in the evening, the patient has pulmonary edema. So watch patients with albumin very carefully. So monitor volume status very carefully when you use albumin. So how do you approach AKI and cirrhosis? Greater than 0.3 increase in serum creatinine, but less than twofold, that is stage 1. If the creatinine is less than 1.5, that is stage 1A. These patients, little less worrisome. You do risk factor management. What is risk factor management? Stop diuretics, stop beta blockers, discontinue non-steroidals, treat infection. If that gets better, just monitor these patients. But if it doesn't get better, that's when you have to replace albumin. But if they come in with a creatinine of greater than 1.5, start albumin at that time. So use that for 48 hours. At the end of it, kidney resolves, go back to monitoring. You don't need to do anything more. But this is not resolved, check the urine, and if these markers are consistent with ATN, consider renal replacement treatment. But if it's consistent with hepatorenal syndrome, you use vasoconstrictors with albumin. And sometimes you're not sure. In these patients, give the patient benefit of doubt and use a vasoconstrictor with albumin. Finally, when will you use renal replacement therapy or dialysis in these patients? Find out whether the patient is a candidate for transplant or not. Patient has ATN. Transplant candidate or non-transplant candidate? Transplant candidate, renal replacement treatment till transplant, they may also require a kidney transplant. They're not transplant candidate, at least for a limited time, we will try renal replacement treatment. HRS AKI, little different. Transplant candidate, we will consider dialysis as a bridge to transplant. If they're not a transplant candidate, Generally, we will not dialyze, but there are some patients with alcohol-related hepatitis where if you treat the alcohol-related hepatitis and they get better, in them, I think it's worthwhile trying renal replacement treatment. So we may consider it in some patients with alcohol-related hepatitis. But often you're never sure whether this is ATN or HRS. In them, if they're transplant candidate, renal replacement is a bridge to transplant. If they're not a candidate, then for a little time we will try this. So to summarize, renal replacement treatment, the decision will be based on etiology of AKI or their candidacy for transplantation. Thank you. And all questions after I leave to Rocky. So it's 90. So I leave you in two extremely good hands to answer all the questions you have on AKI. Okay, thank you so much for your attention.
May I please request Ajay sir to come on stage and felicitate Professor Kamath.
I think, ladies and gentlemen, I think you will agree with me. Can you have a better teaching session than this? No. Everybody is. So I think thank you so much for this. Only he can do this continuously for 5 hours. Big round of applause for Professor Kamath. Only I think he can do it. 5:30 to 9:15, I think continuously he has been talking to us. Big round of applause. And may I request you from a small token of appreciation from INAZL. I request Dr. Pankaj Puri also, who is the treasurer of standing ovation for him first. Okay. Dr. Pankaj Puri is treasurer of INAZL. From the INAZL, just a small token of appreciation. While Professor Kamath has to leave because he has to catch the flight, you probably need to give us 5 more minutes. We also need to felicitate all the faculty for this. And may I request Professor Chawla, ex-director PGI, to please come and felicitate all the faculty chairpersons and the panelists. And please do them. Just call them one by one.
So could I request all the faculty members to call one by one? Professor Premashish Kar sir. Professor Pankaj Puri sir. Professor Sunil Dajit sir. Okay. Dr. Kaushal Madan. Dr. Kaushal is here. Okay. Dr. Ankur Jindal. I can see Professor Anil Arora sir out here. Anil Arora sir. Professor Anup Saraya sir. Professor Saraya. Neeraj Saraf sir. Professor Ashok Chaudhary sir. Dr. Rohit. Chawla sir is there on stage itself. Dr. Ashish Kumar sir. Dr. Bhaskar Nandi sir. I think sir is left. Professor Amit Goel sir. Dr. Narendra Chaudhary sir. Dr. Arka De. Dr. Ajay Kumar sir. Okay. Dr. Brajesh C. Sharma sir. Professor Manoj Kumar sir. Dr. Praveen Sharma. Dr. Babulal Meena. Dr. Piyush Ranjan. And Dr. Raki Maiwal.
Last, Dr. Akash Roy.
And finally, for organizing everything and for this wonderful meet, Professor Ajay Duseja sir. So with this, we call it closure, and I think we've already headed towards dinner.